நானு எல்லாம் நல்லபடியா முடிஞ்சது. பிஸியா இருக்கீங்களா? நான் நாளைக்கு காலையில உங்களுக்கு வர முடியுமா மயிலாப்பூர் போயிட்டு வரதுக்கு? ஆர்டர் போடுறேன்.
This cream need to apply twice a day for 3 to 4 days. Full face, full face. After washing face,
सेफ ड्राइविंग मोड लगा हुआ है ऊपर से बैक
Good evening, sir.
Good evening, madam.
Good evening.
Thank you for joining.
How are you, sir?
Fine.
Full time. Put
நான் வர சொல்றேன். ஆமா ஆமா
528552.
நல்லா இருக்கேன்டா. மீட் பண்ணியிருக்கோம் ரொம்ப நாள் ஆச்சா. சரி சரி. ஓ பையன் டெலிவரி அப்பவா? ஓகே. எனக்கு ஞாபகம் வந்துருச்சு உனக்கு டாக்டர் முருகேஷ் பாபு அனுப்பியிருக்காங்க. சரி உட்காருங்க.
41125559.
அவர்தான் இவரா? ஹலோ சொல்லு. உங்க பேர் என்ன?
DRG.
தன்வி. ஓகே நைஸ். நல்லா இருக்காங்கடா. யார் சொன்னா? என் சிஸ்டர் சொல்லிட்டு இருக்காங்க. வந்தாங்களோ அவங்க?
நீங்க தான் பண்ணீங்க.
பேர் என்னடா?
சுபாதேவி செல்வம் சாரோடைய
யாராவது இல்ல இல்ல. ஓகே அதான் இருங்க. நான் எப்படி ஞாபகம் வச்சுக்கோனா ஏதாவது இந்த மாதிரி ஹிஸ்டரி வச்சு ஞாபகம் வச்சுக்கோனா மீட்டிங் வருது நான் பாக்குறேன். அவங்க இங்க சென்னையில
Good evening, sir. Solomon, sir. Good evening, sir. Good evening.
ஆஃப் பண்ணுப்பா சத்தம் கேட்டுட்டு இருக்கு. Off பண்ணிக்கோ. Okay. இல்லப்பா அது அந்த key இது வந்துட்டே இருக்கு. அது இருங்க.
அங்க போல ஸ்டோர் மீட்டிங் எங்க வெளியே போயிருக்கோம் தோட்டத்துக்கு காய் வாங்கிட்டு போயிட்டியா எங்க அமுச்சிட்டு லிஸ்ட் போனா என்ன எடுக்க சொல்லுவாங்கக்கா எது காய் எடுத்து அமுச்சிட்டு வாங்கி வச்சுட்டாங்கடா எடுக்க லிஸ்ட் அமுச்சிட்டு இது கேட்குறேன்
சார் செந்தில் சார். டாக்டர் செந்தில் சார்.
Sir, good afternoon, sir.
சார் ஆரம்பிச்சிடலாம் சார். பிரசிடென்ட் வந்து அந்த இன்னொரு மீட்டிங்ல இருந்து இருக்கிறார் சார்.
Okay, sir.
நேஷனல்
Okay,
மீட்டிங்ல
sir.
நான் அதுல இருந்தா லீவ் பண்ணிட்டு இங்க வந்திருக்கேன். நீங்க ஆரம்பிச்சிருங்க,
Oh,
சார் ஜாயின் பண்ணுவாங்க சார்.
okay, sir. Okay, sir.
Okay,
Okay, sir.
okay, sir.
Sir, Nirmal sir is there, sir. Sendil sir,
Yes,
இருந்தாங்க நம்ம
yes.
ஸ்டார்ட் பண்ணிக்கலாம், sir.
I'm here, I'm here. We'll start the proceedings. Sendil, are you here? Ibrahim.
Sir, good evening, sir. Sir, we will start, sir.
Yeah, we'll start.
Good evening.
You can request
Yes, sir. I will just, sir.
Solomon
Yes.
Jaya to start
Good
with
evening, all.
IMA prayer.
Now I request our State Finance Secretary, Dr. Solomon Jaya, sir, to give his IMA prayer and official prayer.
Okay, sir. IMA prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lust. Physician prayer. Dear Lord, thou great physician, I kneel before thee. Since every good and perfect gift come from thee, I pray, give skill to my hands, clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and a true realization of the rare privilege that is mine. Take from my heart all guile and worldliness, that with the simple faith of a child I rely on thee.
Thank you, sir.
Thank
On behalf of IMA Tamil Nadu State Branch and the Academy of Medical Specialties, I extend a warm welcome to all our dignitaries, and I warmly welcome you all to this World Cancer Day special webinar on closing the care gap. And I extend my respectful welcome to the State President, Dr. B. Sridhar, who would be joining us soon. He is in another meeting. And also our national AMS leaders, Dr. M. Venkatachalapati, the chairman of National AMS, Dr. B. Amudan, national vice chairman, Dr. C. Sairam, honorary secretary of AMS Wing, and also our IMA Tamil Nadu State Branch office bearers, Dr. P. Senguttuvan, immediate past state president, Dr. A.K. Ravikumar, state president elect, Dr. N.R. state president elect 27, and our own secretary, Dr. Thiramya Mohan, and Dr. D. Solomon Jaya, honorary state finance secretary. I extend a warm welcome to our speakers. Thank you for accepting our invite and joining us today evening for this academic session. Professor Dr. S. Sambat Kumari will be talking to us about HPV vaccination. Dr. Arun Kumar will be a pediatrician turned lifestyle specialist who will be talking to us about nutrition and lifestyle. And Dr. T.V. Ashokan, senior psychiatrist, will be talking to us about tobacco cessation strategy. And also our own wing team, Dr. D. Senthil Kumar, who done a wonderful job of putting together this session, and Dr. Mohammad Ibrahim, Joint Secretary. And a warm welcome to all the delegates. This CME carries TNMC credit hours. And please stay tuned till the proceedings. We can have a wonderful interaction after the three talks. These words, I welcome all of you for this webinar. And over to you, Dr. Sandil, for Secretary.
Thank you, sir. Sir, as our state president, sir, will be joining shortly. Now I request our state secretary, Dr. Dhirve Mohan, sir, to start the CME session and give his address.
Good evening, all. Respected President, the Chairman AMS, Dr. Nirmal Frederick, Secretary, Dr. Sendil, and Finance Secretary, Dr. Ibrahim, and all the national members and the state and the dignitaries and the delegates who are on this CME. First of all, I would like to say the President is there in another CME of the national level. So he'll be joining us as once the meeting gets over. On behalf of the President, I extend warm wishes to the AMS wing for continuing this work. Because when I requested Sendil or 15 days or 1 month back to have a CME on a World Cancer Day, and he readily accepted it, and he has taken the initiative to conduct this program. As you all know, that continuing medical education is not an option; it is a professional responsibility. So, in the era of rapid medical advancement, our strength lives in our commitment to continuous learning and scientific excellence and ethical practice. The programs like this conducted by all the wings, particularly the AMS, CGP, help us to strengthen our knowledge and empower our profession. And I congratulate the AMS wing and all the faculty for the dedicated efforts in advancing the academic excellence. Today we have 3 speakers who are going to talk on main things, the HPV vaccination, lifestyle changes, and tobacco. I think this CME will be a very beneficial to all the delegates, and let us all uphold the dignity of the noble profession and continue to serve the humanity with knowledge and compassion. And once again, thank the AMS wing office bearers for giving me this opportunity and wishing the program a good luck and success. Once again, thank you, and hand it over to the Secretary, Dr. Sendil. Sendil sir can proceed.
Thank you, sir. Thank you, sir, for your kind words. It was our pleasure to conduct this meeting as per our state instruction. Thank you, sir. And now I request our headquarters AMS wing secretary, Dr. Sairam, sir, to give his felicitations.
Yeah, thank you. I'm very happy that this year also you are going to do all the activities like previous year, for which you got the award, national award. Whatever support or whatever guidance, whatever we need to do from headquarters, we are always just a phone call away from you, or just even WhatsApp message to us. We'll get back to you, and we'll try to do whatever best to support you, and we to continue spreading academic activities in Tamil Nadu and all over India. Our national president, chairman, and other my joint secretary, national, and our office also will be at your. Will be available for you in case if I am not able to reach for any reason. So we all unitedly would be helping every state, including Tamil Nadu, which you are actually torchbearer since you with your all efforts, in spite of Telangana having the headquarters office and all the office staff, we could not match your activities. So I congratulate you once again for that achievement and to continue doing the same thing.
Thank you so much, Dr.
Thank you,
Sriram,
sir.
sir. Thank you for the kind words and words for support. We look forward to your guidance and support. Thank you for joining us, sir.
Thank you, sir. Thank you, sir. So now I request our President-elect, Dr. NRTR Tyagarajan, sir, to give his felicitations. I think sir has joined just now.
Yeah.
Hello.
Good afternoon.
போட்டேன் பெட்ரோல் போட்டு வந்துட்டேன். இது என்னது
வந்துட்டேன் கோர்ஸ் பண்ணிடுச்சு இல்லை நம்மளே பண்ணலாம்.
May I request the other delegates to please mute yourself. So over to you, sir. NRTR, sir. Sandil, can we move forward?
Sir, just now sir has joined, sir. I request our state President-elect NRTR Tyagarajan, sir, to give his felicitations.
Okay, okay, yeah. Good evening to all. To the respected President Secretary. This is the second, I think, AMS meeting for the year, and lovely as usual attendance and nice topics. Congrats to the entire team and especially the chairman and the secretary. They're doing wonderful work as far as AMS is concerned. The same attendance that we used to have for the CGP last year, I think, has continued for this. And there's a very good response from most of the doctors. And congrats to them for organizing this. Very good topics. And looking forward to the CME. Thank you, Sandil.
Thank you, sir. And now we have registrations of around thousands just crossed, and we are expecting some more. Thank you, sir. We'll keep up your expectations.
Thanks.
Yes, sir.
Thanks a lot, Sandil. Yes.
So now I request our Joint Secretary, Dr. Ibrahim, sir, who is also a surgical oncologist, to take over the session and coordinate the session. Over to you, sir.
Thank you so much. Once again, I welcome all the delegates and the office bearers, national office bearers, and state IMA office bearers for this wonderful CME on cancer. So as we all know, World Cancer Day, we all celebrate on 4th of February. So we decided to have a CME on cancer management, risk factors, and preventive aspects. So we have selected 3 topics. One is on cancer prevention with HPV vaccination, and another on lifestyle modification, and another on tobacco cessation. All the 3 speakers are well-known, eminent speakers of their own concerned specialties. And we'll have the first speaker now. So the topic is on HPV vaccination. I take the privilege in introducing the first speaker, Professor Dr. S. Sambat Kumari. So she was the Deputy Director, retired in IOG, Madras Medical College. She is at present the president of OGSI, that is Obstetrician and Gynecological Society of Southern India, 2025-26. And also she was the previous vice president in FOGSI in 2022-23 and founder secretary of Tamil Nadu FOG. And she is a member of FIGO Committee on Adolescent and Youth Health Member Onco Committees and national corresponding editor of Journal of OGI and Senate member of Tamil Nadu Dr. MGR Medical University and President Board of Studies OG Tamil Nadu MGR Dr. Medical University
And first ICOG Distinguished General GC Member Award, and she has received 2021 Foxy Dr. DC Datta Award for Best Publication, and 2024 IMA National President's Award and IMA TNSB Awards in 2021, IMA Asan Award and Best Medical Teacher Award in 2024. So we have an eminent speaker now. So over to Professor Dr. S. Sampath Kumari for the first topic. Welcome, madam, please. Madam, you can share your slides. Admin, have you made Sampath Kumari madam as a co-host so that she can share the slides, please? Madam, you have been made a co-host. You can just share the slides, madam. Madam Sampath Kumari madam, you can start sharing the slides, madam. Your voice is muted, madam. Can you just unmute? We are not able to hear you. I think she is logging out and logging in again. So Nirmal sir, shall we wait for some more time, sir, or? I think she is facing some technical difficulties.
Yeah. I'm trying to help her.
Okay, sir.
I'm calling her and trying to help her. Madam, you need to unmute, and you're already a co-host. You can share your screen. Madam, uh, can you disconnect this speaker and talk directly if possible? We're unable to hear you, madam. Sorry, everyone. Madam is facing some technical difficulties. She will join soon. So just bear with us for a minute or so.
Sir, you can take the second program. Sir, you can take the second program.
We're just waiting for her, sir. If she's not able to do, we'll go with the second topic. She's almost there.
Ibrahim, can we go with the second speaker? Madam will join.
Yes, sir. Yes, sir. Yes, sir.
Yeah,
Sure, sir.
we'll sort out the speaker
Arun Kumar.
issues and get back.
Yes, sir. Arun Kumar, sir, are you there, sir? Shall we start the second topic, sir?
If Arun is not there, Dr. Ashokan sir is there.
Okay, sir. So Ashokan, sir, shall we start the third topic, sir, on tobacco cessation?
Yeah, I'm ready.
Thank you, Ashokan sir. So you can introduce.
Welcome once again. Yeah, welcome once again, Dr. TV Ashokan sir. So
Yeah.
Ashokan sir is well known among Stanley people. Me myself, I am also a Stanleyan. So he is the professor in HOD Department of Psychiatry in Sri Muthukumaran Medical College Hospital and Research Institute, Chennai. So he was the editor of Stanley Medical College Journal in 1977, and Honorary General Secretary, Indian Psychiatric Society, Tamil Nadu, Honorary General Secretary, Indian Psychiatric Society, South India in 2001 and 2003, National Executive Council Director, Indian Psychiatric Society 1999 to 2002, Past Assistant Editor, History Section in Indian Journal of Psychiatry, and President of South Zone Branch of Indian Psychiatric Society in 2010, Faculty Member of Mental Health Task Force Indian Psychiatric Society, President Indian Psychiatric Society 2014, and past President Asian Federation of Psychiatric Association, Zonal Representative of South Asia World Psychiatric Association, Honorary Life Member of World Psychiatric Association, and Member of Preventive Psychiatric Committee, and Member of Conflict Management and Conflict Resolution. He has done a lot of oration, including the Professor A.S. Thambaya oration in 2017, Professor Dr. R. Nanjun Rao Endowment oration in 2024, and he has 36 years of teaching experience, conducted PG quiz in psychiatry 25 times at state and regional and national level, presented and published papers in forensic psychiatry and sex in international and national conferences. And he has also authored 3 chapters in textbooks of psychiatry and authored 3 books on mental health in Tamil. So we have a very eminent speaker. Over to Dr. Ashokan sir on the topic on tobacco cessation.
Please, sir.
My PowerPoint is there?
Yes, sir.
Sir.
You can share it, sir. We are not able to see it yet.
1 minute, 1 minute. You are able to see now?
Yes, sir. Yes, sir. Tobacco cessation strategies, we are able to
But
see.
not my photo?
Yeah, your photo is also seen, sir.
Right. But I'm not seeing it right. Fine.
Okay.
Very good evening. Shall I start, sir? Am I audible?
Yes, sir. Very much clear, sir.
Right.
Please, sir.
Very good evening. I'm Dr. Ashokan, psychiatrist, and another 20 minutes I'm going to discuss about tobacco cessation strategies. In this brief lecture, I'm going to discuss about various intervention strategies and other pros and cons of these strategies, and finally, probably the reality in my concluding remarks. Tobacco is considered to be a gateway drug, but unfortunately, people are not able to get away from the drug because of the simple reason of serious physical dependence or psychological dependence, and they have deleterious consequences at the time of withdrawal. What are the various intervention strategies? Behavioral therapy. This is historically, based on learning the information about the first introduction of tobacco to the smoker. The initiating factors, perpetuating factors, or what are the maintaining factors? Was there any kind of a motivation to quit? Was there any brief or sustained abstinence? And what are the relapse signs? All these are analyzed. The physical, psychological, social, and cultural aspects are examined, and the life situations, especially the stressful life situations during which how the individual operated, whether it is a coping strategy, whether it's a minor or major, or a mature or a immature defenses, and a little bit information about health awareness, a little bit information about quality of life on cessation. All these were presented to the individual. Ultimately, the person is probably, instilled confidence to adhere the treatment. Second is the cognitive therapy. This is based on, again, behavioral principle. When a smoker is facing any kind of a situation, whether it's a positive or a negative situation, automatically it develops a thought. And the thought is resulting in unwanted emotions, which are not properly processed in the cognitive realm. And that is resulting in erroneous judgment, which is paving way for smoking behavior. What the therapist does, he asks the smoker to revisit that particular situation of the first time introduction of smoking. And the therapist asks him to think about other possible thoughts in an imaginative way. Then he asks the smoker to substitute the originally occurred automatic thought with the second level thought. Thus, it's possible to alleviate the unwanted emotions, and thus it's possible to retrieve the previous psychological equilibrium. Cognitive behavior therapy is superior, both alone and in combination with nicotine replacement therapy compared with NRT alone. Motivational interviewing, this can be implemented by any health professional, psychologist, psychiatrist, social worker, doctor, specialist. What exactly is happening here? This is a directive, non-confrontational, non-judgmental, active listening with an empathic attitude. I think the person is listening. Next level, what is listen is reflected to the individual, and that is probably creating a kind of an awareness, whether consciously or unconsciously, the person is knowing about the ill effects of smoking, and probably that is also paving way for quitting. Third, acceptance and commitment therapy. The problem with the smoker is that it is not aware of the problem. Once he becomes aware of the problem, next level is acceptance. I'm going to quit. I'm going to stop smoking. But on cessation, on abstinence, I'm going to experience hell of a lot of physical and psychological problem I'm going to withstand. So acceptance is the second level. Then third, commitment. Commitment focuses on what is valued by him. And that is a way to really focus on the motivation to give up smoking. this particular concept is adapted in smartphone applications and web-based interventions. Contingency management and monetary incentive. This is based on a fundamental principle called token economy in the Hospital of Illinois, formulated by Aylan and Asrin. They were treating schizophrenic patients. Most of the schizophrenic patients are chronic with the negative symptoms. They were said to be in a kind of a vegetative state. And the therapist wanted them to really, do a meaningful work, but unfortunately, they were not able to achieve this expected behavior. They thought through some other desired behavior, they could achieve this expected behavior, and here comes the incentive. In an American milieu, in a particular working organization, I think workers know they were selected. Smokers were given a promise that their health insurance policy would be borne, the expenses would be borne by the company. And that was really, a launching pad, and that paid some dividends. But unfortunately, it was not acceptable to other workers who were not smokers. But in the name of the welfare measures, I think that was implemented. But the success of incentive programs depends on the behavior that is being incentivized, whether the person is going to quit or whether he's going to submit himself for treatment, and how the incentive is framed, whether the incentive is going to be a reward or a punishment. This has to be designed properly, otherwise I think it will not work. But more research is needed in this particular incentive program, in which effect is really, whether it is maybe a short-term gain may be there, but in the long run, other factors have to be incorporated. Relapse prevention and recovery strategies. It equips smokers with skills for avoiding with high-risk environment. Imagine a person has abstained from smoking, but he is surrounded by most of the smokers in the work milieu. He is almost like an unlit campfire surrounded by an array of fire. At that time, I think he has to really operate his intellect rather than becoming a prey to his emotions. Acceptance commitment therapy, already I discussed about it. Then motivation enhancing intervention. Periodically, the individual has to be subjected for intensive face-to-face counseling in order to maintain a sustained quit rate. Intervention delivery modalities, self-help materials in a printed format, I think it's really encouraging, but unless until it is tailored to the personal level, it's not going to be effective. Face-to-face counseling, that's a gold standard of all the behavioral treatment, because the therapist has got an opportunity to really, see the patient in person, the smoker in person. And probably he may be asking you, do you consider it as a problem? The smoker may say, no, I don't have a problem. I just smoke. At any point of time, I can stop the smoking. This is a classical denial. And why the hell you're smoking? This particular question, when it is framed, the smoker may retort, no, I just want to forget my agonizing memories. I just want to really concentrate. I feel better. I'm able to focus my attention, concentration during exam time, and it's possible to burn the midnight oil. This is another classical behavior, rationalizing behavior that can be confronted at the time of face-to-face counseling. And that's a period where I think assessment of the motivation is done, and the best possible intervention procedure may be chosen by the therapist. Most of the time, I think smokers, they come into contact with the medical professionals. A brief clinician delivery is 5 years. Ask all the patients whether they are smoking or not. Advise, second year, advise to quit. Then third year, assess the patient's willingness to quit. Then assist in quit attempt and arrange for follow-up. Intensive face-to-face counseling, sometimes it's coupled with the pharmacological interventions, especially for the heavy smokers. I think periodic counseling is necessary. Technology-mediated delivery approaches, telephone-based quit lines, they make a very tall climb, but again, unless until it is incorporating the personal information, the person should feel that it is really, the information is really personal to him, and there should not be any kind of an alien feeling in all the information disseminated in all these quit lines. Health-based interventions, it reduces time, cost, and remotely it can monitor, track, respond to, and deliver an intervention. The cost of delivery is low, but again, there should be multi-call approaches. And outcome is very good with reference to 6 months, but in the long run, I think there is no significant difference between the control and the treatment group. Web-based interventions, they make a tall climb, but again, research is needed to understand what are the specific components that can further enhance the effectiveness of all these interventions. We are living in the world of technology. Empty number of applications are available for anything and everything. But one has to choose the relevant smartphone application. For example, in 2021, there were 228 applications, including 152 on Android platforms and 120 on iOS platforms. But only 12 applications in 2021 and 11 in 22 had published their results. So when you're going for applications, smartphone applications, identify whether it is relevant, evidence-based. And there is a cause and effect relationship between psychological issues and addiction. So there should be comprehensive evaluation of mental health issues that has to be incorporated in all these applications. Pharmacological treatment, there are 3 drugs. One is the nicotine, second is the bupropion, and third is the vernaculine. Nicotine is available in the form of patch, gum, lozenge, nasal spray, oral inhaler, 2 milligram or 4 milligram. Heavy smokers, they may be needing higher dose. Nicotine replacement therapy delivers nicotine to alleviate the physical dependence without exposing the individual to the toxic materials generated by combustion and other additives. And not only that, it delivers the nicotine in a lesser concentration, that thereby reducing the behaviorally reinforcing effect of smoking. All NRTs have same efficacy, but heavy smokers, they have higher dose of NRT, more than 4 milligram, or dual regimens of NRT. Bupropion, it blocks reuptake of dopamine and to lesser extent of norepinephrine. Again, it blocks nicotine receptor. It increases dopamine and norepinephrine in the brain, stimulating the nicotine effect. In rats, low bupropion blocks the nicotine rewarding effect. So it's ideal to really, initiate bupropion to really address the withdrawal symptoms. Start with 150 milligram, escalate up to 300 milligram. If the individual is not tolerating, revert back to 150 milligram, which is still a beneficial dose. It is resulting in less weight gain, but the quit rates between bupropion and placebo after 1 year, there is no significant difference. Side effects, very rarely mood changes, may be requiring hospitalization. Vernaculine, it's a partial agonist of alpha-4 beta-2 nicotine acetylcholine receptor subtype, which mediates dopamine release. This is a major receptor in nicotine addiction. Activating the receptor produces 50% of nicotine, and thus it is relieving the nicotine withdrawal. Start with 0.5 milligram OD first day, 4th day 0.5 milligram BD, and 1 milligram BD on the 7th day. Vernaculine is more effective than placebo, nicotine patch, and bupropion. Side effects include nausea, vomiting, insomnia, and depression, psychosis, aggression, and suicidality. Combination pharmacotherapy for heavy smokers or people with lesser motivation, and if they start showing signs of relapse within the period of 6 months, I think dual regimens of NRT is better than single form of NRT. Vernaculine plus bupropion or NRT is better than vernaculine for heavy smokers. Bupropion plus nicotine patch better than bupropion alone. There is another concept of preloading medication. Imagine a situation where an individual wants to quit smoking on the New Year Eve. Even before that, by December 15th, a nicotine patch is probably given to him, and they compared an individual with the preloading and individual without preloading. They claim that the quit rate is more among the preloading people. Gradual reduction. Person smoking 20 cigarettes per day, that is being reduced to probably 15, 10, and 5. Again, this is construed as just maintenance of smoking and nothing else. May be ideal as an interim strategy. People who are not having any kind of a motivation, maybe, those people, I think they can be on this particular gradual reduction based on harm reduction concept. Extended treatment. NRT package should be used for only 8 to 12 weeks. After that, medications have to be initiated for a period of 1 year. Precision medicine, meta-analysis of all the researches with reference to smoking, I think they are probably encouraging results are there with reference to abstinence rate up to 6 months. But beyond 1 year, very, very few researches are there where quit rates are rarely surpassing 30%. So there is an impending need to find out a novel intervention strategy for these smokers. Smokers differ from each other in many ways. Metabolism, I think, slow versus rapid metabolism, I think that is an ideal factor to be really analyzed and further researched. Rapid metabolizers smoke heavily. CYP2A6 is the chief metabolizer of nicotine. CYP2A6 metabolizes nicotine, it's converting into cotinine, and that is further reduced to 3-hydroxycotinine. The cotinine 3-hydroxycotinine ratio is a biological marker of nicotine metabolism. And all these products, I think, metabolites, they can be measured in plasma, urine, and blood. Normal metabolizers, they respond better to bupropion than to nicotine patch. Slow metabolizers respond well to nicotine patch. Nicotine patch equally effective as vernaculine for slow metabolizers. Other precision medicine approaches based on pharmacogenomics, there's one particular study that was highlighting superior efficacy of vernaculine relative to bupropion and NRT. Females responded better than men. But again, mental health conditions can really, interfere the behavioral and pharmacological treatments. Combination treatments, I think highest quit rates are there with combination treatments. Modified and alternative tobacco products, very low nicotine content cigarettes. Decrease in nicotine with comprehensive cessation, there's a better impact. E-cigarettes, electronic nicotine delivery system, they are called as vapes, vape pens, tanks, mods, and pod mods. These are all battery operated devices. There is a liquid called e-liquid, and the e-liquid is invariably vegetable glycerin or propylene glycol. And this particular e-liquid is converted into a kind of an aerosol, which when inhaled, it really delivers nicotine, some flavorings, and other compounds. But again, the evidence is inadequate for smoking cessation. Teachable moments. Smoker is coming into contact with the hospital. I think he may be admitted for some surgical procedure, or he may be submitting himself for some investigative procedure, or he may be hospitalized for tobacco-related distress. This is an ideal time to really, talk to him. And this is the ideal time to instill confidence, and probably, acceptance ratio is more. And these are the teachable moments. And lung cancer screening with low-dose computed tomography, that is associated with 20% lower mortality than a chest X-ray. This is the time, I think, you can really, possible for clinicians to deliver cessation intervention to this high-risk population. What are the evidences that are sufficient? Counseling and medication better than self-help group, because self-help groups, the person, he is not feeling it personal. Counseling and medication independently effective, more effective in combination. Combination is the rule for the smokers. Proactive quitline counseling alone or in combination with medication increases cessation. Short text message services, effective if they are interactive and tailored to the personal level. Web-based interventions effective only with behavioral techniques and interactive components. Combination of nicotine replacement therapy is better than single form of NRT. Teachable moments influence quit rates. The evidences that are insufficient, smartphone applications, they are generally saying something, but not really personally addressing. There is no use at all, and it is not evidence-based, and it is not peer-reviewed. Preloading medication, only very few papers are available, and very low nicotine content cigarettes, I think the smoking is maintained. E-cigarettes, no evidence at all. Interventions, further studies, they fail to replicate the findings. Cytosine, it is not really, alleviating smoking habits. In the present level, go for metabolism of nicotine. Normal metabolizers, I think they respond well to bupropion. Slow metabolizers, go for nicotine if they are not responding, combined with bupropion. And rapid metabolizers, they have to be on intervention, combined intervention strategies. 6 months abstinence is construed as a better cessation, but unfortunately, researchers are not really encouraging beyond 6 months because only very rare, studies, rarely they say the quit rate is surpassing 30%. So heavy smokers, combined interventions are the rule of intervention. And probably the last one is my take-home point, I think, availability, affordability, accessibility. These are all the factors. In every general hospital, I think with reference to quit rate beyond 6 months or beyond 1 year, I think we are with a pessimistic cognitive pendulum, say, like expecting a light in the other end of the tunnel. But with the formation of OP, outpatient department, in each and every general hospital with a multidisciplinary professionals comprising of psychologists, psychiatrists, physicians, other officials, I think it's possible to illuminate the tunnel itself. Thank you very much.
Thank you so much, sir, for your wonderful presentation and detailed explanation and clarity on tobacco cessation and also the mechanism. I think we can have the discussions and doubt clearing sessions at the end of all the three speakers. And I request all the delegates who are attending the CME to write their name, the TNMC registration number, their mobile number, and also from which branch, IMA branch they are from. And also they have to enter the email ID also for getting the TNMC credit points. And now we'll have the second topic. So this is on lifestyle modifications, and I request Dr. Arun Kumar to unmute. Sir Arun Kumar, I'll just give a brief description of Dr. Arun Kumar's profile. So Dr. Arun Kumar is professionally a MD pediatrics. He did from Bangalore Medical College in 2011 to 2014. And he is also an alumni of Stanley Medical College. In fact, my junior by 4 years. He's from 2003 to 2009. And his work experience currently working as a consultant pediatrician and nutritional expert in Baby Hospital in Erode. And previously he has worked as a consultant pediatrician and neonatologist in KMCH, Erode, and Kaveri Hospital, Hosur. And he's a past chairman of Tamil Nadu IMA Lifestyle Modification and Wellness Committee and special invitee member of Tamil Nadu Government ICDS Scheme Nutrition Committee and author of best-selling Tamil book on nutrition titled Arogyam Or Plate, and has been interviewed in major mainstream media and has been regularly writing columns for magazines pertaining to childcare, nutrition, and medical issues. And he runs a popular YouTube channel for health awareness with almost 1.3 million plus subscribers. And he has won Dr. Jairam Memorial Award granted by IAP Bangalore BPS and got distinction in general medicine in final year MBBS and district rank holder in Tamil Nadu Higher Secondary Examination in 2003. Publications, he has 2 international publications on Biomedical and Elsevier Journal of Pediatrics and 1 publication in the National IAP Journal. And his special areas of interest are obesity and dietary management of lifestyle disorders, and has guided more than 20,000 adults and pediatric patients for dietary management of obesity, diabetes, PCOS, dyslipidemia, fatty liver, and other lifestyle disorders. And he has been invited as speaker in National Pediatric Conference in 2025 and speaker at State Pediatric Conference is 2022, 24, and 25. And speaker at State IMA Conference, Erode Timacon in 2019 and 2023. And he's a speaker in various national and state level IMA and IAP meetings, and served as organizing secretary of 2 state level conferences, Wellness Conclave and PaleoCon, and 1 district level conference in Erode. So over to Dr. Arun Kumar.
Ibrahim sir, can you hear me?
Yes, sir.
No. Sampath Kumari, no problem. I just want to. No.
Okay. Dr. Arun Kumar? Sir, are you there?
அங்க ஆன் பண்ணி வச்சுட்டு நீங்க மட்டும் வேலை பண்ணுவீங்க.
Sir, you can ask the madam to talk, sir.
Ibrahim, sir. Hello.
Yes, sir. Yes, sir. Yes, sir. Yes, madam. I'm able to hear you. Yeah.
Illa, he has written, ask madam to talk.
Okay. Okay. Are you ready, madam? Shall we start your
Yes,
topic?
I am ready. Shall I try my screen, share screening?
Yes. Yes.
Have
Yes,
made me
madam.
a
Yes, madam. We
co-host,
can go
sir.
ahead. Yeah.
Have you made me as
Yeah, you are
co-host?
already, madam. You are already.
No, I am
Yeah. Already
not
you
a
were.
co-host.
I think since you went and came back, I think it's not made. Juliet, ma'am, can you make Sambat Kumari ma'am as a co-host, please? Or shall I share, madam?
Yes, sir. No problem. You can share. Are you sharing or they have made me as a co-host?
I'm sharing, madam. Are you able to see?
Yes, sir. Yes, sir. I can see. So good evening to all. Sorry for the inconvenience. Today we will go and talk about the HPV vaccination. Next slide, sir. Next slide. See, the World Cancer Day, united by unique. That is on February 4th. See, next slide. This is our CA cervix. See, now the cancer cervix. Next slide, sir. Next. The cervical cancer. This is the fourth most common cancer in women globally. Now, per year, around 6,60,000 new cases has been identified. And of this, 3,50,000 deaths are there. So, cervical cancer is the second leading case of cancer death among women in India. So, in India, it is the second leading cause. And above the global death due to the cervical cancer, 25% is in from India. Next slide. Next. So in India, cervical cancer contributes to approximately 6 to 29% of all cancer in women. It is highest in Mizoram and lowest in Dibrugarh. Why this cancer contributes to 6 to 29% is most of the time the screening is not done everywhere. Now, as per the literatures, the screening in India is only 10 to 12%. Next slide. So this is the cervical screening, which everywhere now the screening incidence is very, very less. Next slide. Next, sir. See, now coming to the cervical cancer, what are all the causes? Now you had the wonderful talk by Vashokan sir, the smoking and the immune system, use of long, if you are using continuously the OC pills, and the external factors, genetics and HIV positive. Of all this human papilloma virus, 90%, more than 90% of the CA cervix is mainly due to the human papilloma virus. What is this human papilloma virus? Next slide. See, this is our human papilloma virus. This human papilloma virus has different strains. Next slide. See, we have around more than 200 strains in the human papillomavirus. The human HPV is the common cause for the CA cervix and the sexually transmitted disease both in women and men throughout the world. Next slide. See, this human papillomavirus, as I told, it is 200 strains. Of this, whichever is causing the CA cervix, the low risk and the high risk being the next slide. Next, sir. Next. The high-risk HPV types include the 16, 18, 31, 33. These are all the high-risk types. So this HPV high-risk types, when got infected, there is a possibility for the CA cervix. The low-risk types are, next, sir. Next slide. The low risk is 6, 11, 42, 43, and 44. So generally, the HPV is more than 200 strains. Of this STD types which produces the infections are the high risk types and the low risk types. So what happens with this HPV infections? Next slide. See, among this, as I told, the 16 and 18 is the high risk cases. With this HPV 16 and HPV 18, about 70% of the cervical cancer occurs due to this 16 and 18. That is the reason we talk about the bivalent. Then of this 16 and 18, 16 causes approximately 50% of the cervical cancers worldwide. So the additional 5 high risk types, which I told earlier, this 31, 33, 45, 52, 58, they are all responsible for the 15% of the cervical cancer and 11% of the HPV associated cancers, not only cervical, even the throat cancers in the man and the vaginal cancers. These are all due to the human papillomavirus. So the 16 and 18 is the common. Of this other risk, HPV is also there. So that is the reason we have the bivalent vaccine, quadrivalent vaccine, nanovalent vaccine. The next slide. This bivalent can be act with the 2 strains and the for quadrivalent for 4 strains, nanovalent for 9 strains. Why we want to talk about this HPV vaccine during the adolescent? See, always the cancer cervix is in the later stage, but now when the adolescents are vaccinated, that is up to the 14 years, this is because of the HPV virus. They are vaccinated, we can reduce the incidence of cervix, CA cervix, because as all of us know, the scomo-columnar junction, that is the endocervix lined by the columnar epithelium, ectocervix lined by the squamous epithelium. The meeting point, the scomo-columnar junction, is the site for CA cervix. So at this site only the metaplastic changes occurs. The greatest metaplastic activity occurs at puberty and during the first pregnancy, and after menopause it is reducing. That is the reason we want to focus the HPV vaccinations in the adolescents, that is during the puberty. Next slide. Next. So the HPV vaccine, this human papilloma virus vaccine protects against the human papilloma virus infection that can cause the cancers, that is the cervical, anal, throat, and the genital warts. Even for this warts will go for the cancer changes in future. So being most effective before sexual activity. That is the reason we tell by 9 to 14 years the HPV vaccination has to be given, or at least before the sexual activity. This vaccination has to be given. Next slide. Next. So now we are telling that the human papillomavirus is the cause for CA cervix. Of the 16 and 18 is the common cause. So now we are telling the HPV vaccination will prevent. What is the dose? The dose recommendation for this prevention of CA cervix is the primary recommendation for girls and boys. Mainly it is in the adolescent period, that is 9 to 14 years. The dose schedule, when it is given in the 9 to 14 years, is 2 doses enough. That is the duration between the 2 doses can be 6 to 12 months. When the vaccine is given from 15 to 26 years, as we tell before the sexual activity. Now the latest advance we are giving even up to 45 years. That is 3 doses. The 3 doses is one the 0 dose, next at the 1 month, and the next at the 6 month. So 15 to 26, extended up to 42. 3 doses has to be given. So this 3 doses, what we are advising now is the quadrivalent. So up to 14 years, it is the 2 doses. After that, it is 3 doses. Next slide. It is the simple vaccine. See, even the IAP and the FOXI guidelines, they all recommend the HPV vaccination as girls aged 9 to 14 years as the 2 doses, that is in between the 6 months. And the catch-up vaccination, as I told earlier, it can be given up to the 45 years. Nowadays, after the delivery, even during the postnatal period, we are advising. This vaccine only contraindication is immunocompromised patients, and during the delivery, we are not giving. But other patients up to 45, we can give the 3-dose scheduled is, as I told earlier, 0, 1, and 6. This is the guidelines which is followed. But whenever you give the vaccines, there are 2 types of the vaccines are kept. The brand names. One is Cervavac and another is the Gardasil. Suppose if you are giving the Gardasil vaccine, all the 3 doses, the Gardasil should be given. You cannot change that. If you are going to go with the Cervavac, but it is the quadrivalent only, whether the quadrivalent or the nanovalent, all the doses, the same brand has to be given. The next slide. See, now the latest. Next, sir. This is the name, Cervavac, Gardasil 5, Gardasil 9. This Gardasil 9 is the nanovalent. That can help the 9 strains of the HPV. But the previous 2 can help for the 4 strains. So, these 4 strains which I have told. The quadrivalent will prevent the 4 strains, and the nanovalent, it is available only in the Gardasil. It will prevent the 9 strains. The quadrivalent, girls and boys 9 to 26 years, it can be given. Gardasil 5, now they have extended up to the 9 to 45 years. And the nanovalent, girls is for 9 to 26 years and boys is for 9 to 14 years. See, by every time, depending on the price, the nanovalent is the little costliest, but it has the good effect. The next slide, because it can act for the 9 strains. Next slide, sir. So this is our nanovalent. The quadrivalent, as I told, 16, 18, 31, 33, only for this 4 strains. But this nanovalent, Gardasil 9 will act for the 16, 18, 31, 33, 45, 50 to 58 high risk, and also the low risk of 6 and 11. So it will be helpful for the genital warts. Whether it is the quadrivalent or nanovalent, the 3 doses has to be given after the 14 years. The next slide, sir. See, what this is our WHO, World Health Organization. What they are telling now, previously we were talking about the same HPV vaccinations. In between, it was not given due to by 2030, this 90-70-90 has to be followed. That is the reason the FOXI is giving training, IMA is giving training, even the government is doing the same thing. That is 90-70-90 means 90% of the adolescent girls should have been vaccinated before 2030. That is the 2 doses. And the second 70 is women. That is after 75 years. The women has to be screened for CA cervix. Now we have different types of the screening. Pap smear can be done and visual inspection with acetic acid and iodine. That is with the Magna Vision, we can visualize the cervix. The cervix will be magnified for 10 times. If needed with the colposcopy. Now the liquid-based cytology is also there. If the liquid-based cytology, you can detect the HPV virus also. With the colposcopy, the cervix will be magnified 40 times. Now we can see the squamo-columnar junction. That is the columnar cells and the squamous cells joining. That is the transformation zone. So there has to be diagnosed. That is whether it is the CAN1. CAN1 is the neoplasia that is in the earlier stages, CAN2 or cervical intraepithelial neoplasia. If the patient is diagnosed as CAN1, it will take 10 to 15 years to become the CA cervix. So if they are screened and if they are diagnosed as CAN1 and CAN2, the third 90, that 90% of the diagnosed person has to be treated. Suppose the woman is 40 years and if she has been screened as CAN1, we can go with the removal of the transformation zone. That is the cryotherapy can be given. Or we can go with the large loop excision of the transformation zone. Some laser procedures are there. So if you are going to give the treatment means we can prevent the CA cervix. So 90% of the girls has to be vaccinated. 70% of the women has to be screened. 90% of the women screened and diagnosed has to be treated. Suppose post-menopausal women diagnosed as CAN1 means we will go with the hysterectomy and the other procedures. So depending on the age and depending on the infections, we have to be treated. See, if everyone is following this only, by 2030, the CA cervix incidence will reduce. Because as of now, the screening percentage is less than 10% and vaccination percentage is only 11%. So all of us should do this screening and the vaccination. Next slide. See, now the screening, WHO recommends, not only with the government, they are recommending the importance of monitoring and evaluating, that is with the local leaders. And we have to give the educational campaigns and the partnership with the schools. Now the Tamil Nadu government has started that giving the vaccination in the schools in 4 districts. So the healthcare providers, the education is very, very important. Next slide. Next, sir. So the collaboration, so the government, NGOs and the healthcare providers, if they work together only, this 90, 70, 90 target will be reached. See, when we are during 2020, all of us had the COVID vaccine. We didn't bother about what will be the side effect because of the seriousness of the COVID. Similarly, if everyone is going to focus on this vaccination and screening, definitely by 2030, at least the 50% can be achieved. The next slide. So from the Tamil Nadu Federations and the IMA, we have joined with the NHM and we are doing this partnership because the partnerships, the Rotarians, they are also giving the vaccinations in the schools. If the vaccination is given, it is only a simple vaccine. It is given in the deltoid region. It is only the IM injections, small dose. If it is followed everywhere from throughout, then the incidence of the CA cervix will get reduced. The next slide, sir. So what is the barriers? Why this vaccination is not given? Because they think that there is no the education and the cultural benefits, the cultural beliefs, and we have to talk about the importance, the healthcare providers to talk about the importance of the HPV vaccination. See, if the CA cervix identified at the 4th stage, the prognosis is very, very bad. If it is identified screening at the earliest stage, the prognosis will be good. So for the MMR, we are having the audit. Like that for the CA cervix maternal death or mother death also, the audit has to be given. So this is the barriers. Addressing these barriers will be made successful for the HPV prevention and the control. Next slide, sir. Next slide. So now in our Tamil Nadu, we had the special steering committee from the NHM and the health secretary. We had with the IMA representations and the IAP, and the meeting was conducted on January 22nd. And the 4 districts, I think Ariyalur, Perambalur, Dharmaburi, and Tiruvannamalai, the vaccine has been given. Last Monday, they have started. For 9 to 14 years, they are giving the bivalent 2 doses, the quadrivalent vaccine for all the government schools. So if we private practitioners with IMA and the TNFJ, if you are going to give for the other school students also, we can reduce the incidence of the CA cervix. Next slide, sir. So I request all of them to give this HPV vaccination. This is the project which I told it was launched last week by our Chief Minister, and the 4 districts which I told is Ariyalur, Dharmaburi, Perambalur and Tiruvannamalai. In this 4 districts, I think within 2 months, all the government school girls between 9 to 14 years will have the 2 doses of the vaccination. The next slide, sir. So now we are having a training, and by this, the next slide, sir. 17th, we have the training at the NHM. They have called the TNFOG and the IMA and the IAP doctors. So we should train the doctors in the district, and we should make all the doctors. It is the duty of all the healthcare providers to make the HPV vaccination available for the adolescent, and to make the parents mainly to understand that this HPV vaccination will prevent the CA cervix in future. The minor side effects, there is no much side effects. I have given until now around more than 2,000 vaccination. There is slight fever and the headache only. Other than that, no complication is present. So all of us should start giving the HPV vaccination. Next slide, sir. So which is the best? People can ask whether we have to give the Gardasil or Sarvaveka. Everything is the quadrivalent, 6, 11, 16, 18. Everything has the same action. whatever is available, which the patient prefers, Gardasil or the Cervavac, whichever. Some medical students, they come with the telling that we want the Gardasil. Some the Rotarians, they go with the Cervavac. Whatever may be the vaccine, something should be given. Both are best only. The next slide, sir. So these are all the routine questions asked by the people. Do we need multiple doses of HPV vaccine? It is not needed. In the Australia, they have mentioned that by 2023 itself, they have come with a single dose vaccinations. They have approved that a single dose itself is enough. But in our places, we are giving the 2 doses for the adolescent, and after 15 years, we are going to give the 3 doses. The next slide, sir. So these are all the questions which the public is having. That is the reason I mentioned everything. What is the misconceptions? There is some people believe that if you give the HPV vaccine, there is affect the fertility, and the girls will go for the sexual activity. But there are literatures, and it is proved that the fertility will not be affected, and it will not encourage the girls to have the sexual activity. We have to give the counseling and the teaching. Education is very, very important. Next slide, sir. So the implementations. Now this implementation, the district levels. So in our state, they are implemented at the district levels. From the district level, it has to go to the municipal level. From the municipal level, everyone. So if each the healthcare provider is going to vaccinate at least 50 girls, I think most of them will be vaccinated, and the incidence will get reduced. And our WHO target 90, 70, 90 can be reached. Next slide, sir. So parents. So always when I was working with the adolescent committee of Foxy, see, if we go to the schools, always not only talking to the adolescent, we have to talk to the parents. The parents should be counseled that it plays the HPV vaccination is very, very important. Whenever I am giving the vaccination, we have a Google form. In this Google form, we will get the parents' consent. So it doesn't mean the signature. That is the oral information, sir. The Google form that your girl is going to be vaccinated. So if the parents' education is very, very important, then only it will be for the girls to have the vaccine will be easier. Always give counseling for the students, counseling for the parents, and the counseling for the teachers. If you are going to give in the schools, means the teachers should know what will be the effect, how long. Once the vaccination is given, the girl should be vaccinated, sit there at least for 10 minutes. After 10 minutes only, she should leave from this place. Next slide, sir. So the message to parents and teacher is very, very important. So the whole, if you combine together only, the parents, teachers, and the adolescents has to be counseled, the healthcare workers and the Rotarians and the government, everyone should work together. Then only with the HPV vaccination will be successful. So in conclusion, HPV vaccination is a scientifically proven, safe and highly effective strategy to prevent cervical cancer. So cervical cancer is the only cancer, if you are identified it earlier, you can prevent the complications. So it will take the CAN1 to go for CA cervix 10 to 15 years. So if you are identifying the infection in CAN1, means with the treatment, we can prevent the cancer. So given the high burden of HPV 16 and 18 infections, timely immunizations of adolescent girls can prevent thousands of cancer cases in future. So this depends on the community engagement, health systems, and the evidence-based implementation. Next slide, sir. Thank you. I think this is the last slide. So as he told, after the next speaker, if any doubts, we can take up the questions. Thank you, Ibrahim, sir, for focusing.
Thank you, madam, for the wonderful presentation on HPV vaccination. You have cleared a lot of doubts and common myths about HPV vaccination. And as of now, cancer cervix is one of the leading causes of mortality and morbidity in India. And with this mass HPV vaccination, we can reduce the burden, cancer burden in India.
Yes.
And we'll have the question session at the end of the program. And I request all the delegates to post their doubts in the about 2 topics which have been already discussed in the chat box, so that we can discuss it at later. And now we'll go to the 3rd topic, which is on lifestyle modifications in management of or prevention of cancer. And we have already had the introduction of the speaker, Dr. Arun Kumar. I think Dr. Arun Kumar has already joined. And over to Dr. Arun Kumar, you can share it, sir. Please go ahead, sir.
Okay, sir. Thank you. So, good evening, everyone. I thank IMA AMS committee for giving me the opportunity. to speak about how the right food and lifestyle can reverse the lifestyle diseases. So, when thinking about this topic, Dr. Senil Kumar sir was telling about how the main theme is cancer prevention. So, like I said, like sir, my main domain is obesity. So, how to link both? So then I just went through the data. So always when we think lifestyle risk factors of cancer, the common things that come into our mind is smoking, alcohol, and some plastics and other things. And now Madam spoke about the HPV vaccination, the unprotected sex, cervical cancer. So these are all the common factors which everyone generally know that these are common risk factors for obesity. But how are the obesity, diabetes, and the metabolic syndrome? These diseases are how they are linked to obesity. So I'm just going through a Lancet recent paper published in 2019. So smoking, undoubtedly, it is the number one cause of preventable risk factor for all the cancers combined. The second is alcohol, and the third is high body mass index. Fourth is unsafe sex, so which the smoking already spoke about it regarding the cessation strategies. Ma'am spoke about the HPV vaccination, the unsafe sex, and the fifth is diabetes. So when you combine this high body mass index and the high fasting blood sugar, the diabetes, the risk burden is more than the alcohol and unsafe sex. So next, only to smoking, it is the number two cause of preventable reasons for cancers. So such is the burden. So we always equate cardiac diseases, coronary heart disease, stroke, and other diseases with obesity and metabolic syndrome. But we rarely think of cancers linking to obesity. But such is the burden that is almost it is the number two cause of preventable reason for all the cancers combined. So that is why. So speaking about this obesity and metabolic diseases in a cancer prevention seminar makes it more important. So I got this paper, this newspaper article just today morning, and many a recent journal is the many of the leading authors, they are trying to classify obesity as a chronic disease, not as a lifestyle disease, but as a chronic disease. So that's since a lot of drugs have come up, lots of treatment options, bariatric surgeries are there. So the body wants to change the diagnosis, the classification, so that effective interventions can be made. But how far do they work, and how to actually, we know that it is a number one problem, and we know it is creating a havoc in our society, causing all sort of diseases, but how to tackle it? So that is the problem. So what causes increase in obesity or metabolic syndrome recent days? So the common misconceptions are many, everyone you ask, like they will tell junk food is the reason, physical activity is less these days. Then people might tell some previously in our olden years, எங்கள் தாத்தா பாட்டிலாம் நல்லா வயலில் வேலை செஞ்சாங்க, ஆனால் நம்மளாம் வேலையே செய்யறதில்ல. ஸோ அப்போ நம்ம வந்து வேலை செய்ய ஆரம்பித்தோம்னா நமக்கு ஒல்லியாயிடலாம் அப்படின்னு. So even the recent Coca-Cola had a important message for us. They told that one, you can eat even Coke, but if you do good physical activity and if you run properly, then you can come out of obesity. This is what some researchers sponsored by Coke had told in 2015. And I just went through an important journal, so not many know about it. So an important published in PLOS One. So it is linking hunter-gatherer energetics and human obesity. So நாம் என்ன நினைப்போம், ஸோ எல்லாம் காட்டில் இருக்கிறவங்க அப்படிலாம் பயங்கரமாக வேலை செய்வாங்க, ஸோ அதனால் அவங்க கேலோரிஸ் வந்து அதிகமாக பேர்ன் பண்ணுவாங்க. ஸோ வி கேன் ஈஸியாக அவங்களுக்கு வந்து கேலோரிஸ் பேர்ன் ஆகிடும், அதனால தான் அவங்க ஃபிட்டாக இருக்காங்க அப்படின்னு நம்ம நினைப்போம். So they compared three groups of people. So that is the Western, a typical Western or urban population, ஒரு கிராமத்தில் இருக்கிற ஒரு ஃபார்மிங் அக்ரிகல்ச்சர் பேஸ்ட் பாப்புலேஷன், டிபிக்கல் ஹண்டர் கேதரர் பாப்புலேஷன், ஹட்ஸா அவங்க வந்து ஹண்டர் கேதர் பாப்புலேஷன் ஆஃப்ரிக்கா, தே ஸ்டில் தே ஹண்ட், தே கேதர் அண்ட் தே சர்வை. ஸோ இது 3 பேத்துக்கும் what is the average calories expenditure per day அப்படின்னு they have checked. So what they have found is the energy expenditure in the did not differ significantly between any of the groups. ஸோ வெஸ்டர்னர்ஸுக்கு என்ன எனர்ஜி எக்ஸ்பெண்டிச்சரோ, அந்த கிராமத்தில் இருக்கிற விவசாயிகளுக்கு என்ன எனர்ஜி எக்ஸ்பெண்டிச்சரோ, the ஹார்ட்ஸா hunters and gatherers, everyone had the same energy expenditure. This will be shocking to many of the people who say that, advocate that நம்ம முன்னோர்கள் நிறைய வேலை செஞ்சாங்க, எனர்ஜி எக்ஸ்பெண்டிச்சர் ஜாஸ்தி இருந்துச்சு. ஸோ இட்ஸ் இம்பார்ட்டன்ட் ஸ்டடி. ஸோ இட் in another meta analysis also echoed the same results. ஸோ நவ் அது ஏன் அப்படின்னு அவங்க கண்டுபிடிச்சாங்கன்னா, ஸோ அவங்க ஃபிசிக்கல் ஆக்டிவிட்டி அதிகமாக இருந்துச்சுன்னா the body metabolic rate actually decreased automatically to make sure that உங்களுக்கு நெட் எனர்ஜி லாஸ் பர் டே வந்து எக்ஸ்பெண்டிச்சர் அரௌண்ட் ஒரு 2200 கேலரிஸ் மாதிரியே போகிற மாதிரி நம்ம தான் வந்து உடம்பு ஆட்டோமேட்டிக்கலி அட்ஜஸ்ட்ஸ் த பாடி. ஸோ தட் இஸ் வாட் அன் இம்பார்ட்டன்ட் ஃபைண்டிங் விச் வாஸ் ஃபவுண்ட் ரீசென்ட்லி இன் த ரிசர்ச். So always we say calorie centric theory of weight loss. So if we consume less calories and burn more calories, we can lose weight. So in such situation, this is the old dietary guidelines by USDA. So a typical food pyramid: cereals at the base, vegetables and fruits, then oils, fats and proteins on the top, and that to be taken minimally. And after this, how is the change in the dietary pattern? The carbohydrate consumption has increased, the fat percentage has decreased, protein almost remained the same in US. This is the US data. But after the publishment of this low fat guidelines, actually the obesity kept on skyrocketing. So the diabetes kept on skyrocketing. அட்லீஸ்ட் ஃபேட் எல்லாம் நம்ம குறைச்சோம், அட்லீஸ்ட் சிஹெச்டி குறைஞ்சுதா, கொரோனரி ஹார்ட் டிசீஸ், ஸ்ட்ரோக் குறைஞ்சுதா அப்படின்னு பார்த்தா அதுவும் வந்து குறையல. ஸோ ஆல் த வாஸ்குலர் டிசீசஸ் ஆல்சோ தே இன்க்ரீஸ். ஸோ வாட் இஸ் த ப்ராப்ளம்? ஸோ இப்போ நம்ம கம்மியாக ஃபேட் எடுக்கிறோம், கம்மியாக கேலரிஸ் எடுக்கிறோம். இஃப் திஸ் குட் கிவ் அஸ் மெட்டபாலிக் பெனிஃபிட், then all these diseases would have actually decreased in incidence or prevalence. So why this paradox? So இது ஒரு பழைய படத்தில் ஒரு காமெடி வரும். ஸோ செந்தில் வந்து ஒரு மலையை தூக்கிட்டு, நான் மலையை தூக்க போகிறேன் அப்படிம்பாரு. எப்படி தூக்க போகிறேன்னு எல்லாம் டிக்கெட் பார்த்துட்டு வாங்கிட்டு வெயிட் பண்ணிட்டு இருப்பாங்க. அப்புறம் ரெடியாக அங்கே இருப்பார்.
என்ன உட்காந்துட்டீங்க, போய் மலையை தூக்குங்க. ஒரு 50 பேரை கூப்பிடுறா. எதுக்கு? இந்த மலையை தூக்கி என் கையில வைக்க சொல்லு, தூக்கணும்ல. 10 ரூபாய் டிக்கெட் வாங்கணும், கேட்க மாட்டான்.
ஸோ இந்த மாதிரி ஒரு காமெடி இருக்கும், நீங்கள் எல்லோரும் பார்த்துருப்பீங்க. ஸோ நம்ம சிம்பிளாக நம்ம திரும்ப திரும்ப சொல்லிகிட்டே இருக்கோம். ஸோ எப்படி டாக்டர் வெயிட்டு குறைக்கிறதுன்னு கேட்டால், ஒன்றும் இல்லைங்க, கம்மியாக சாப்பிடுங்க, அதிகமாக ஒர்க் பண்ணுங்க அப்படின்னு சொல்கிறது எப்படியோ இந்த செந்தில் பட காமெடி மாதிரி தான் இருக்குது. ஸோ திஸ் இஸ் த ரீசன்ட் எக்ஸப்ட் ஃப்ரம் த ஹாரிசன் டெக்ஸ்ட் புக். So it clearly says that this is the obesity chapter. The exquisite regulation of energy balance cannot be monitored easily by calorie counting in relation to physical activity, because it depends on a complex interplay of hormonal and neural signals. So with weight loss, appetite increases and energy expenditure falls. So நாம கம்மி பண்ண ட்ரை பண்ணோம்னா ஆட்டோமேட்டிக்காக பசி ஜாஸ்தி ஆகிடும், எனர்ஜி எக்ஸ்பெண்டிச்சர் குறைஞ்சிரும். ஸோ இதனால தான் simple calorie calculation fails. So this is what given in recent Harrison textbook of medicine in obesity chapter. So this is why I was telling about, there is a complex interplay. There is hypothalamus, there are lots of hormones, central controllers of appetite. There are hormones which decrease, and there are hormones which increase the appetite, and there are lots of psychological factors, vagal, gut peptides, metabolites, hormones, leptin, insulin, cortisol, cultural factors. Lots of factors have a complex interwoven interplay in managing obesity. So obesity is a combination of a genetic trait along with a poor diet and imbalanced physical activity. So this we all know. So whenever there is obesity, due to the excess free fatty acids, lots of adipokines and cytokines, inflammation which is leading to insulin resistance. Because of insulin resistance, to counter the insulin resistance, the pancreas is secreting more insulin, which is leading to hyperinsulinemia, that is elevated levels of circulating insulin. That leads to more fat accumulation and worsening obesity. ஸோ நீங்கள் இதில் எல்லா டிசீசஸையும் இதனால் நம்ம சொல்லிடலாம். ஸோ because of insulin resistance, there is overworking of pancreas, and beta cell dysfunction, which is leading to diabetes. So liver there is increased triglyceride synthesis, fatty liver, and dyslipidemia, high triglyceride, low HDL. Activation of renin, angiotensin, aldosterone system, vasoconstriction, sodium and water retention, which is leading to hypertension. Again, obese hypertension vardana, this is the pathway. So ovarian dysfunction, androgen excess, excess LH, which is leading to PCOD, infertility, which is the number one cause nowadays. So நீங்கள் என்னென்ன லைஃப் ஸ்டைல் டிசீஸோ எல்லாத்தையும் இன்சுலின் கூட நம்ம லிங்க் பண்ணிடலாம். ஸோ இப்போ டயட்டில் என்ன தான் அப்ரோச் பண்ணுறது? ஸோ ஃபஸ்ட்டு வயிறு நிரம்பணும். ஸோ த ஹேட் பி இம்ப்ரூவ்டு சட்டைட்டி. ஸோ ஹவு டு இம்ப்ரூவ் த சட்டைட்டி? இட் ஹேஸ் டு பி நியூட்ரியன்ட் டென்ஸ் ஃபுட் ராதர் தென் அ கலோரி டென்ஸ் ஃபுட். அது என்னன்னு பார்க்கலாம். ஸோ தென் ஹார்மோன்ஸ், கண்ட்ரோலிங் த ஹார்மோன்ஸ், மெயின்லி கண்ட்ரோலிங் த இன்சுலின். So insulin ku maina we have to reduce the carbohydrates and increase the proteins, and consolidation of meals, proper timing and regulation of the meals. So brain, so there is lots of hedonic pathways. So always we see food as a reward. So நம்ம ஒரு ரீல்ஸ் பார்க்குறோம், ஒரு புது ஹோட்டல் பற்றியோ புது ஐட்டம் பற்றியோ சொன்னோம்னா சந்தோஷமாக அது பசியே இல்லைனாலும் அதை சாப்பிட்ணும், ஆர்டர் பண்ணணும், ஸ்விக்கி ஜொமேட்டோவில் ஆர்டர் பண்ணணும்னு நினைக்கிறோம். ஸோ பிரெயின் இமோஷனல் ஈட்டிங் இந்த மாதிரி பாத்வேஸும் இருக்குது. ஸோ இதையும் நம்ம பிஹேவியரல் இன்டர்வென்ஷன் மூலமாக கண்ட்ரோல் பண்ணும். ஸோ நம்ம கட், நம்ம ஹார்மோன்ஸ், நம்ம பிரெயின் மூணுமே இஃப் வி கண்ட்ரோல் வி கேன் கான்குவயர் திஸ் மெட்டபாலிக் சிண்ட்ரோம். ஸோ ஃபஸ்ட்டு டயட்டில் நான் சொன்ன மாதிரி, ஸோ we know, so carbohydrates mainly stimulate insulin, and proteins and healthy fats do not stimulate insulin. So a carbohydrate restriction along with the calorie restriction, not a simple calorie restriction, carbohydrate with calorie restriction, consolidation of meals, high intensity exercises, high nutrient density. So high nutrient density na enna? For example, இப்போ 500 calories, ஒரு 2 தோசை சாப்பிட்டாலும் 500 calories, ஒரு half plate பிரியாணி சாப்பிட்டாவே 500 calories, ஒரு 2 மைசூர் பாக் சாப்பிட்டாலே 500 calories, ஒரு பஜ்ஜி, இது பசி அடங்குமா? அதே 500 calories, நான் சில எக்ஸாம்பிள் சொல்கிறேன். 7 முட்டை, 1.25 கிலோ கேரட், ஒரு 300 கிராம் பாயில்டு கிரீன் கிராம், ஒரு 3/4 தேங்காய், அப்புறம் 100 கிராம் பாயில்டு பீனட்ஸ், ஒரு ஹாஃப் கிரில்டு சிக்கன், அல்லது ஒரு 1.5 கிலோ வாட்டர்மெலன், கிட்டத்தட்ட ஒரு முழு பழமே. ஸோ இது வயிறு நிரம்புமா? ஸோ திஸ் இஸ் த டிஃப்ரென்ஸ் பிட்வீன் கலோரி டென்சிட்டி அண்ட் இது. ஸோ நம்ம சிம்பிளாக கலோரி கவுண்ட் பண்ணி 4 தோசை சாப்பிட்றோமா, நாளையிலேருந்து நான் 2 தோசை சாப்பிட போகிறேன்னு நம்ம கவுண்ட் பண்ணோம்னா இட் வில் லீட் டு ஃபெயிலியர். ஸோ வி ஹாவ் டு ஃபில் வித் அ நியூட்ரியன்ட் டென்ஸ், லோ கார்போஹைட்ரேட், குட் ப்ரோட்டீன். ஸோ இதுதான் பேசிக். ஸோ மோர் ப்ரோட்டீன், ஹெல்தி ஃபேட்ஸ், மோர் ஃபைபர் அண்ட் லெஸ் கார்ப்ஸ். ஸோ இதுதான் டயட். ஸோ வாட் அபவுட் ஃபிசிக்கல் ஆக்டிவிட்டி? ஸோ இப்போ நம்ம சொல்கிறோம் ஃபிசிக்கல் ஆக்டிவிட்டி என்ன, அதோட கேவியேட் என்ன, அது டிஸ்அட்வான்டேஜ் என்ன, ப்ராப்ளம் வெறும் ஃபிசிக்கல் ஆக்டிவிட்டியில் அப்படின்னா, ஸோ நம்ம வெறும் ஃபிசிக்கல் ஆக்டிவிட்டி பண்ணால் வெயிட் லாஸ் ஆயிரும்னு நினைக்கிறோம். பட் டசன்ட் ஒர்க் தட் வே. ஒரு 1 hour வாக்கிங் போகிறோம், வர வழியிலே ஒரு டீ வடை குடிச்சிட்டு வராங்க, சரியாக போயிடும். ஒரு 45 minutes ஜாகிங் பண்ணுறோம், ஒரு பிஸ்கட் காஃபி சாப்பிட்டா சரியாக போயிடும் அந்த கேலரிஸ். 1 hour சைக்கிளிங் பண்ணுறீங்க, 2 ஸ்வீட் சாப்பிட்டா சரியாக போயிடும். பட் வாட் இஸ் த ரோல் ஆஃப் ஃபிசிக்கல் ஆக்டிவிட்டி? மாடரேட் எஃபர்ட் கார்டியோ ஆக்டிவிட்டி, அது வந்து இம்பார்ட்டன்ட். அது என்னென்ன? பிரிஸ்க் வாக்கிங், மாடரேட் பேஸ் ஜாகிங், சைக்கிளிங். ஸோ நம்ம உங்கள் ஸ்ட்ரெஸ், உங்கள் ஜாயின்ட்ஸ் அண்ட் டெண்டான்ஸை ஸ்ட்ரெஸ் பண்ணணும்னு அவசியம் இல்லை. The primary purpose of cardio activity is not to burn more calories but to improve the aerobic capacity. So muscle strengthening exercises, அது எதுக்கு? சும்மா ஜிம்மில் போய் நிறைய கஜமுஜன்னு தூக்கி நம்ம பாடி பில்டர் ஆகிறதுக்கா? இல்லை. It increases the lean body mass, increases the muscle mass, and increases the resting basal metabolic rate. மசில் மாஸ் அதிகமாக இருந்துச்சுன்னா சும்மா உட்காந்துட்டு இருக்கிறப்பே நிறைய கேலரிஸை உடம்பு எடுத்துக்கும். ஸோ ஃபார் த சேம் BMI, ஃபேட் பர்சன்டேஜ் குறையும், விச் அகைன் இம்ப்ரூவ்ஸ் த இன்சுலின் ரெசிஸ்டன்ஸ். ஸோ வயசாகும்போது நம்மளுடைய ஜாயின்ட்ஸ் நல்லாயிருக்கும், மசில் மாஸ் நல்லாயிருக்கும். தட் இஸ் வை எக்ஸசைஸ் இஸ் இம்பார்ட்டன்ட். ஸோ அதை நீங்கள் ஒரு ஸ்போர்ட்ஸாகவும் நீங்கள் கம்பைன் பண்ணி பண்ணுறீங்க அப்படின்னா தனியாக ஒர்க் அவுட் பண்ணுறதை விட இட் வில் பி சஸ்டைனபிள், என்ஜாயபிள் அண்ட் ஆல் என்கம்பாசிங். ஸோ ஃபிசிக்கல் ஆக்டிவிட்டினா அவர் எஃபர்ட் ஷுட் பி அட் திஸ் லெவல், நாட் ஜஸ்ட் ரேண்டமாக ஒரு வீடியோ பார்த்துட்டு திடீர்னு போய் ஜிம்மில் போய் பணம் கட்டி கஜமுஜன்னு பண்ணி ஜாயின்ஸை டேமேஜ் பண்ணிக்கிறது கிடையாது. ஸோ ஹவு டு டேக் கேர் ஆஃப் த பிரெயின் கட் ஆக்சஸ்? ஸோ சப்ரஸ் த டோபமின் ஹீடானிக் ரிவார்ட் சிஸ்டம், டிஸ்கனெக்ட் ப்ளஷர் அண்ட் ஃபுட். என்ன சொல்கிறாங்க? ஸ்வீட் எடு கொண்டாடுன்னு தான் விளம்பரப்படுத்துகிறான் சாக்லேட்டு. அப்படி இல்லாமல் அவாய்ட் ட்ரீட்ஸ், ஈட்டிங் அவுட், கிஃப்டிங் ஸ்நாக்ஸ் அஸ் அ ரிவார்ட் சிஸ்டம். எப்பவுமே நம்ம சந்தோஷத்தோட நம்ம பிரெயின் அப்படியே இன்டர்ட்வைன் ஆயிருக்கு. சந்தோஷம்னா ட்ரீட்டு, வெளியே சாப்பிட்றது, ஆர்டர் பண்ணுறது, இப்படி இல்லாமல் அதை ரெண்டையும் டீலிங்க் பண்ணணும். மைண்ட்ஃபுல் ஈட்டிங், அவாய்டிங் கேட்ஜெட்ஸ் ஆர் டிவி வைல் ஈட்டிங், லிசன் டு அவர் பாடிஸ் ஹங்கர் அண்ட் ஃபுல்னஸ் சிக்னல்ஸ், ப்ராப்பர் ஃபீட்பேக் மெக்கானிசம், ஒரு மெயின்டைனிங் அ டயட் டைரி. ஸோ முக்கியமாக இதெல்லாம் பேசியாச்சு. ஒரு முக்கியமாக எலிஃபெண்ட் இந்த ரூம் பற்றி நம்ம பேசல, என்னன்னு சொல்கிறேன். ஸோ தெர் ஆர் லாட்ஸ் ஆஃப் ஷார்ட் கட்ஸ் பீப்புள் ஆர் ட்ரையிங். வெயிட் லாஸ் ட்ரக்ஸ் இப்போ நிறைய வந்திருக்கு. ஸோ ஒசம்பிக் மாஞ்சாரோ, ஸோ அப்புறம் நிறைய ப்ரோட்டீன் ஷேக்ஸ் நிறைய பேர் என்ன யூஸ் பண்ணுறாங்க, பேரியாட்ரிக் சர்ஜரி. ஆனால் இதுக்கெல்லாம் என்ன காமன்? டூ தீஸ் டைரக்ட்லி ரெடியூஸ் த பாடி வெயிட்? ஸோ வெயிட் லாஸ் ட்ரக்ஸ் போயிட்டு த்ரூ அ மெக்கானிசம் தே கண்ட்ரோல் த appetite. ப்ரோட்டீன் ஷேக்ஸ் போயிட்டு இட்ஸ் அ மீல் ரீப்ளேஸ்மெண்ட். ஸோ நீங்கள் ப்ரோட்டீன் எடுக்கிறீங்க, கார்ப்ஸ் குறையுது, தே டூ அ மீல் ரீப்ளேஸ்மெண்ட் அண்ட் கேலரி டெபிசிட், அதனால் வெயிட் லாஸ். பேரியாட்ரிக் சர்ஜரி சேம் மெக்கானிசம். ஸோ போர்ஷன் கண்ட்ரோல் பண்ணுறோம், ஒரு ஸ்லீவ் கேஸ்ட்ரெக்டமியோ இல்லை ரூன் வை பைபாஸ் பண்ணும்போது அதனால் சாப்பிட முடியாது, அதனால் வெயிட் லாஸ் ஆகுது. ஸோ சுற்றி நம்ம டயட்டுக்கு தான் வந்தாகணும். ஸோ GLP-1 அனலாக்ஸ் ரீசெண்டாக வந்திருக்கு. So how it works? So this GLP are the drugs which through an action they increase the insulin, decrease glucagon, slow down the gastric emptying and slow down the gastric motility, and in brain, as I said, in hypothalamus decrease the food intake. So ஒரு லாங் ஆக்டிங் GLP-1 அனலாக்ஸ் கொடுக்கும்போது நமக்கு பசி மூமெண்ட் குறைஞ்சு அதனால் வெயிட் குறையுங்கிறது ஒரு தியரி. ஒரு ஒபீஸ் டயபெட்டிக்கு இது ஒரு ஹெல்ப்ஃபுல்லாக இருக்கலாம். பட் வித்தவுட் டயபெட்டிஸ் ஒரு ஒபீஸ் பர்சன் இதனால் வெயிட்டு குறைக்க முடியும், ஓகே, சஸ்டெயின் பண்ண முடியுமா பார்த்துருவோம். ஸோ ரீசெண்ட் சிஸ்டமேட்டிக் ரிவ்யூ அண்ட் மெட்டா அனாலிசிஸ் பப்ளிஷ்ட் இன் BMJ இன் திஸ் இயர். வாட் இட் ஃபவுண்ட்? ஸோ சே ஒரு நார்மல் ஒரு சிம்பிள் ஏதோ ஒரு இன்டர்வென்ஷனில் ஒரு 5 kg வெயிட் லாஸ் ஆகுது ஒரு பீரியட் ஆஃப் 36 months அப்படின்னா, ஸோ தீஸ் ட்ரக்ஸ் த ஓல்டர் இன்க்ரெட்டின் மெமிக்ஸ் GLP-1 அனலாக்ஸ் அரௌண்ட் ஒரு 8 kg ஆவரேஜ் வெயிட் லாஸ். இந்த நியூயர் இன்க்ரெட்டின் மெமிக்ஸ் வந்து பார்த்தீங்கன்னா ஆல்மோஸ்ட் ஒரு 10 to 15 kg வெயிட் லாஸ். நல்லா இருக்கே அப்படின்னு தோணலாம். ஆனால் once you stop the drug, the rebound weight gain is so fast that within 1 year you will reach the baseline weight and you will even the overshoot the baseline weight. ஸோ நீங்கள் ஒரு பிஹேவியரல் இன்டர்வென்ஷன்லையோ டயட்லேயோ வெயிட் லாஸ் பண்ணுறவங்களுக்கு குறையுது, ஏறனாலும் பழைய வெயிட்டை தாண்டதில்ல. ஆனால் நீங்கள் ட்ரக்ஸில் வெயிட் லாஸ் பண்ணுறவங்க பார்த்தீங்கன்னா நீங்கள் உங்கள் பேஸ்லைன் வெயிட்டை விடவே நீங்கள் தாண்டிடுவீங்க. ஸோ அப்போ இந்த ட்ரக் எவ்வளோ நாள் எடுக்கணும்? லைஃப் லாங் எடுக்கணும். ஸோ தட் இஸ் த எலிஃபெண்ட் இன் த ரூம். ஸோ அதனால் லைஃப் லாங் ஒரு வெயிட் லாஸ்க்காக ஒரு ட்ரக்கை எடுக்க முடியுமா யோசிக்கணும். ஸோ ஆல் த பாலிசி ஃபார்முலேட்டர்ஸ் ஷுட் திங்க் அபவுட் இட். இது எப்படி ஒரு சஸ்டைனபிளாக இருக்கும் அப்படிங்கிறத யோசிக்கணும். ஸோ அப்போ நம்ம ப்ராப்பர் லைஃப் ஸ்டைல் இன்டர்வென்ஷனில் ஐ வில் ஸ்பீக் அபவுட் மை எக்ஸ்பீரியன்ஸ் இன் அ நட்ஷெல். ஸோ ஐ கைடட் more than 20,000-25,000 patients. I am adopting various approaches, but the basis is therapeutic carbohydrate restriction in variable levels. ஏன் therapeutic carbohydrate restriction சொன்னோம்னா இப்போ பேலியோ லோ கார்பன் சொன்னால் அது இட்ஸ் an extreme version. ஸோ அது ஒருத்தருக்கு தேவைப்படும், இன்னொருத்தருக்கு சம் ஃபார்ம் ஆஃப் கார்போஹைட்ரேட் ரெஸ்ட்ரிக்ஷனே போதுமானதாக இருக்கும், ஒருத்தருக்கு அதோட ஒரு மீல் ரெஸ்ட்ரிக்ஷன் ஒரு ஃபாஸ்டிங் ஹெல்ப்ஃபுல்லாக இருக்கும். ஸோ அதோட ரிசல்ட்ஸ் நான் ஜஸ்ட் காமிக்கிறேன். ஜஸ்ட் இது ஒரு ஸ்டடிக்காக பண்ணது. ஒரு 3 months ஆவரேஜ் வெயிட் லாஸ் வாஸ் மோர் தென் 12 kg. ஒரு சின்ன ஒரு குரூப் ஒரு 100-200 பீப்புள் ஒரு ஸ்டடிக்காக பண்ணது. ஸோ ஜஸ்ட் ஐம் டெல்லிங் ஒரு ரீசெண்ட் இன்னைக்கு நேற்று வந்த ரிவ்யூ வந்த பேஷண்ட்டு ஜஸ்ட் ஒரு 3 to 4 months ஹி லாஸ்ட் மோர் தென் 20 kg. ஸோ HbA1c கேம் டவுன் சிக்னிஃபிகண்ட்லி, ட்ரைக்ளிசரைட் டிக்ரீஸ், யூரிக் ஆசிட் 8.5 to 5.8 வித் இன்க்ளூடிங் அவர் நான்வெஜ் எல்லாம் எடுத்து ஒரு நான்வெஜ் பேஸ்ட் டயட்டில் வீக்லி 5 days எடுத்து இந்த அளவுக்கு குறைஞ்சிருக்கு வித் வெயிட் லாஸ். இன்னொரு பர்சன் ஆல்மோஸ்ட் ஒரு 60 kg மேலே வெயிட் லாஸ். எப்படி மற்ற பேராமீட்டர்ஸ் இம்ப்ரூவ் ஆகுதுங்கிறது பாருங்கள். இன்னொன்று, ஸோ சஸ்டைனபிளாக லாங் டேர்ம் ஒரு டயட்ரி இன்டர்வென்ஷன், பிஹேவியரல் இன்டர்வென்ஷன், நம்ம எப்படி அந்த மெடிசன் சஸ்டைனபிளான்னு பேசணும். ஒரு டயட்ரி இன்டர்வென்ஷன் ப்ராப்பர் ஒரு கைடன்ஸ் இருந்தால் டெஃபினெட்லி அவங்களுக்கு இப்படின்னு நம்ம சொன்னோம்னா டெஃபினட்டாக இது பண்ண முடியும். ஸோ ஆல்மோஸ்ட் 1 person ஸோ ஒரு 20 kg குறைச்சிட்டு ஆல்மோஸ்ட் ஒரு 3 years சஸ்டைனபிளாக மெயின்டைன் அண்ட் ஆல்சோ ரிவர்ஸ் மோஸ்ட் ஆஃப் த மெட்டபாலிக் இஷ்யூஸ். தட் ஃபீமேல் வாஸ் ஈவன் ஏபிள் டு stop her psychiatric drugs. Even spoke about it in recent state psychiatric conference. Even the antidepressants she was able to come out of it. So diabetics, HbA1c excellent reduction. So நிறைய பேர் வெயிட் குறைக்கிறதுனால நம்ம குறையும் நினைப்பாங்க, பட் கார்போஹைட்ரேட்ஸ் குறைக்கும் போது ஈவன் லீன் டயபெட்டிக் இந்த பர்சன் பாருங்க ஆல்மோஸ்ட் 72 kg. ஸோ வித்தவுட் அ சிங்கிள் kg ஆஃப் வெயிட் லாஸ், ஈவன் அவர் வெயிட் ஒரு 4 வருஷத்தில் 2 kg ஏறி இருக்காரு, பட் HbA1c கம் டவுன் ஃப்ரம் 12 to 6.5. ஸோ லீன் டயபெட்டிஸ்க்கும் வேலை செய்யும், ஃபேட்டி லிவரில் ஒரு ப்ராப்பர் வெயிட் லாஸ் ஹெல்ப் பண்ணும். ஹைப்பர் ட்ரைக்ளிசரைடுமே ஆக்சுவலி திஸ் பர்சன் ஃபெமிலியல் ஹைப்பர் ட்ரைக்ளிசரைட்ஸ் 980 triglycerides to 298 with just dietary intervention without any drugs. Even statins இருந்தாரு, அதுவும் நமக்கு யூஸ் இல்லை ட்ரைக்ளிசரைடுக்கு, அதை ஸ்டாப் பண்ணிட்டோம். ஸோ இட் கேம் டவுன் சிக்னிஃபிகண்ட்லி. ஸோ இன்ஃபர்டிலிட்டி, PCOS மேடம் இருக்காங்க, இட்ஸ் நைட் ஆப்பர்ச்சுனிட்டி ஃபார் மீ டு ஸ்பீக் அபவுட் இட். ஸோ நிறைய ஒபீஸ் PCOS வெயிட் லாஸ் ஹெல்ப் பண்ணும் தெரியும். ஈவன் லீன் பிசிஓ எப்படி நான் லீன் டயபெட்டிக் காமிச்சனோ லீன் பிசிஓக்கும் கார்போஹைட்ரேட் ரெஸ்ட்ரிக்ஷன் பண்ணும்போது ரொம்ப சிக்னிஃபிகண்ட் எக்ஸலண்ட் ரிசல்ட்ஸ் இருக்கும். ஸோ 10 years 12 years infertility இருப்பாங்க. வி புட் them on a low carb diet within 5 to 6 months they just get conceived naturally without even any intervention. ஸோ ஒரு மினிமல் வெயிட் லாஸ்லேயே நல்ல ஒரு இது வரும். லீன் பிசிஓ இஸ் எக்ஸலண்ட். ஐயுஐ ஐவிஎஃப் ஃபெயில்டாக இருப்பாங்க. வி புட் them on a dietary intervention, they improve. இது இல்லாமல் நான் சொன்ன மாதிரி நிறைய ஜிஐ டிஸார்டர்ஸ், ஃபியூ ஆட்டோமியூன் சொரியாசிஸ் ரெமிஷன் ஆகிறத பார்க்குறோம். ஃபியூ எபிலெப்சி வந்து கண்ட்ரோல் ஆகிறத பார்க்குறோம். ஸோ அலர்ஜிக் இஷ்யூஸ் கண்ட்ரோல் ஆகிறத பார்க்குறோம். ஸோ லாட்ஸ் ஆஃப் பெனிஃபிட்ஸ் வி ஹவ் சீன். பட் எனி சேஞ்சஸ் அப்படி ஒரு 10 years நம்ம வி ஆர் ஸ்பீக்கிங் அபவுட் த கார்போஹைட்ரேட் ரெஸ்ட்ரிக்ஷன் இன் தமிழ்நாடு ஆஃப்டர் பிக் மூமெண்ட் ஃப்ரம் த ஃபேஸ்புக் ஆரோக்கியம் நல்வாழ்வு அதெல்லாம். ஆனால் இன்னும் ஃபேன்சி வெயிட் லாஸ் சென்டர்ஸ் இருக்குது. இன்னும் மக்கள் பவுடர்ஸ் ஷேக்கு குடிச்சிட்டு இருக்காங்க. இன்னும் கஜமுஜன் ஏதாவது ஆக்டிவிட்டி பண்ணுறது இருக்குது. இன்னும் ஷார்ட்கட்ஸ் ட்ரை பண்ணிட்டு தான் இருக்காங்க. போன வாரம் கூட யாரோ போராக்ஸ் பவுடர் சாப்பிட்டுட்டு ஒரு பாப்பா பரிதாபமாக வந்து இறந்துருக்காங்க. ஃபேன்சி ஃபேட் டயட்ஸ் இன்னும் ரீல்ஸ் பார்த்து ஃபாலோ பண்ணிட்டு இருக்காங்க. இன்னும் ஹை அண்ட் க்ளூட்டன் ஃப்ரீ ஆன்டி இன்ஃப்ளமேட்டரி டயட்டுன்னு நடிகர்களை வச்சு விளம்பரம் போயிட்டு தான் இருக்குது. ஸோ ஒய் இன்னும் பீப்புள் ஆர் இன்னும் கொஞ்சம் மெடிக்கல் கம்யூனிட்டியிலே ஒரு கன்ஃபியூஷன் ரெசிஸ்டன்ஸ் இருக்குது. ஃபேட் நல்லதா ப்ரோட்டீன் நல்லதான்னு. பீப்புள் ஷுட் கம் அவுட் ஆஃப் இட். ஸோ பீப்புள் ஆர் நாட் வில்லிங் டு கம் அவுட் ஆஃப் ட்ரெடிஷ்னல் ப்ராக்டிசஸ். இன்னும் நம்ம மில்லட் சாப்பிட்ணும் அல்லது சும்மா அளவு கம்மியாக சாப்பிட்ணும். ஃபால்ஸ் ப்ரொப்பகண்டா பை த மீடியா. இன்னும் கொஞ்சம் மக்கள் டேஸ்ட்க்கு அந்த ஹீடானிக் பாத்வேஸ் நிறைய இஷ்யூஸ் இருக்குது. ஸோ நான் சொன்ன மாதிரி ஐ ஆல்வேஸ் கோட் திஸ். ஸோ செமல் வைஸுங்கிறது தான் ஹேண்ட் வாஷ் பண்ணால் வந்து கிருமி அழிவுன்னு கண்டுபிடிச்சாரு. ஸோ இவருக்கு நோபல் ப்ரைஸ் கொடுத்தாங்களான்னா இவர் மென்டல் அசைலமில் போட்டாங்க. ஸோ அதுதான் இக்னாஸ் செமல் வைஸோட கதை. ஸோ ஹேண்ட் வாஷ் பண்ணால் கிருமி அழிவுன்னு சொன்னவருக்கு கிடைச்சது கிஃப்டாக மென்டல் அசைலம். அட்லாஸ்ட் ஹி டைட் இன் மென்டல் அசைலம், இக்னாஸ் செமல் வைஸ். ஸோ அந்த மாதிரி ஆகாமல் டெஃபினெட்லி a proper change should be done for this tackling this growing pandemic of this lifestyle problem. But change is inevitable. Recent pure study, so fats and carbohydrate வந்து என்ன இம்பேக்ட்னு பார்க்கும்போது it clearly proved, published in Lancet, high carbohydrate intake was associated with higher total risk of mortality, and total fat and individual types of fat were related to lower total mortality. American Diabetic Association had reversed the guidelines. Recent study, ICMR India B study, clearly they told least carbohydrate intake இருக்கிறவங்களை விட highest carbohydrate intake இருக்கிறவங்களுக்கு they had high type 2 diabetes and pre-diabetes. Replacing refined cereals with whole wheat or millet flour without decreasing the carbohydrate quantity was not associated with the lower risk of type 2 diabetes. Clear-ஆ சொல்லிட்டாங்க recent India B ஸ்டடியில். ஸோ நீங்கள் நீங்கள் 4 தோசைக்கு பதிலாக 4 ராகி தோசை சாப்பிட்றது எந்த பெனிஃபிட்டும் கிடையாது. நீங்கள் ஓவராலாக 4ங்கிறது 2 தோசையாக குறைச்சாலோ 1 தோசையாக குறைச்சா வேணால் பெனிஃபிட் வரலாம். ஜஸ்ட் ரீப்ளேசிங் வித் அனதர் சீரியல் நோ யூஸ். கிளியராக சொல்லிட்டாங்க. ஐசோகேலரிக் சப்ஸ்டியூஷன் ஆஃப் கார்போஹைட்ரேட்ஸ் வித் ப்ரோட்டீன்ஸ் அண்ட் டைரி அண்ட் ஹெல்தி ஃபேட்ஸ் அது வந்து உங்களுக்கு டெஃபினட்டாக ஹெல்ப் பண்ணுங்கிறது கிளியர் கட் ப்ரூவ்டு. ரீசெண்ட் ட்ரம்ப் கவர்மெண்ட்லேருந்து யூஎஸ்டியோட கைட்லைன்ஸ் நான் சொன்னேன், அந்த பழைய பிரமிட், அந்த பிரமிடே தலைகீழாக தூக்கி போட்டு சீரியல்ஸை கடைசியாக முக்கோணத்தோட கார்னரில் வச்சுட்டு ஹெல்தி ஃபேட்ஸ் எல்லாம் தாராளமாக எடுக்கணும். ப்ரோட்டீன்ஸை வந்து ப்ரோட்டீன்ஸையும் வெஜிடபிள்ஸையும் ஃப்ரூட்ஸையும் டாப்பில் கொண்டு போயிட்டு ஈவன் யூஎஸ் ஹேஸ் கம்ப்ளீட்லி சேஞ்ச் த டயட்ரி கைட்லைன்ஸ். ஸோ வாட் ஆர் யூ வெயிட்டிங் ஃபார்? So let's embrace this life-changing diet pattern and make the world healthier. Thanks for the opportunity. Thank you.
Thank you, Dr. Arun Kumar, for the wonderful presentation in your usual interesting way. There are a lot of things discussed here. So I guess the delegates would have received a lot of useful information from this presentation. And now we request the questions discussion. I think all the speakers are here. So there were some doubts being posted in the chat box. Madam, for Sampat Kumari Madam, there is a question for you. So
yes,
it is, yeah. So there's a question which is, what should be the gap between the first and second dose? I think I've already mentioned it. The first and second
dose. Up to 14 years, there should be 6 months. From 14 to 45 years, 3 doses. You should give the first dose, within 1 month, second dose, and from the first dose, 6 months, third dose.
Okay, madam, it's a clear thing. And another interesting question is, after completing the vaccination, when we should start screening and till what age? Screening for cervical cancer.
Yes, sir. Vaccination, it doesn't mean that if you have given the vaccination, there is no necessity for screening. The screening protocols always we are doing After the 30 years, once in 2 years, still the 3 values is becoming negative. So if you are giving the vaccine means as per the age, you can give the screening. Screening and vaccination has no connections because vaccination usually we are going to give before the sexual activity. So screening we are going to start after the 33 to 35 years. Screening procedure is as like other persons.
Okay, madam. Well said. And there is another question on what about vaccination for boys and adults? Adults, I think they mean adult males. They are asking, I guess.
Males, boys, as of now it is up to 9 to 12 years or maximum of 26 years. It will prevent penile cancer, anal cancer, and throat cancer. Not beyond 26 years. But for the ladies, we are extending up to 45 years. So it can be given from 9 to 12, 14 is ideal age, or if at all needed, up to 26 years, not more than that. For boys.
Okay.
And I saw
another
one
question, madam,
sir.
is there
Vaccination, whether it will interfere with the puberty? I saw one question. So the vaccination will never interfere with the puberty or it will never interfere with the infertility. It can be given.
Is there any pelvic rest after HPV vaccination for married women?
No, there is no need for the pelvic rest. Suppose the vaccine, as I told, is first dose, second dose after 2 months, and third dose after 6 months. Once the 3 doses were over, that 1 month rest before becoming pregnant. If at all they are becoming pregnant in between, means there is no need to bother. We can have the third dose after the delivery. There is no need for the pelvic rest.
Okay. I think these are the questions.
Sir.
Yeah.
Can I ask, sir?
Yes, sir. Yes, sir.
Yes, sir.
Like Tamil Nadu has accepted a vaccination program as a part of HPV vaccination.
Yes,
Is it
sir.
true?
Yes, sir. Tamil Nadu now doing the pilot study. As I told in the last Monday itself, they have started. Ariyalur, Perambalur, Tiruvannamalai, and Dharmaburi. For all the adolescent girls in the government school, for all the girls they are giving. It is the pilot study already started. And we attended the committee meeting also, the steering committee meeting. And they are going to bring this throughout the state in future.
When it is likely to be launched? Because already pilot study was done in our state also from Government of India. Then at that time there was a few problems, but that problems got magnified, and we had to stop that WHO sponsored trial. So
no, sir, another trial. They have launched only last Monday.
Monday. This one is a good one. What I request is that at least this pilot study, no such extra, over enthusiasm of media and our own colleagues had spoiled that pilot study in Kakinada, and we had to wait for almost 15 years from the launch of the universal vaccination in most of the countries. Actually, we were the part of that study, and our ethics committee chairman had to go to Delhi and explain the parliament standing committee why approval was given for the study and all those things. So at least what I request is this particular pilot study should not end up in getting that fate, and we should see that it is implemented all over Tamil Nadu, and followed by that rest of the country also should follow that one, I feel.
Yes, sir. All of us should cooperate. The same thing in the Bihar they have done for all. So we will. I think it will not get spoiled, sir. It will go. Now they have combined with IAP, TNFOJ, IMA. All of us are doing this HPV. Education is very, very important, sir. Education.
Very good presentation, madam.
Thank you, sir.
Sir, thank you, sir, Sairam sir, for your active participation in the discussions also. So for all others, Sairam sir is the IMA AMS Honorary Secretary from New Delhi headquarters, IMA AMS headquarters. Thank you, sir, for your participation. And is Dr. Dr. Arun Kumar is there, sir. So there is a
Ah,
question
yes,
for
sir.
you. Sir, Arun Kumar
Ah,
says,
yes.
yes, sir.
Ah,
There is
yes,
a
sir.
question. So what laws public are moving to Colors Health Loss Center in view of nutritional, dietetics or herbal, no side effects, whether they are right? I think what the person is
I think
asking is
already,
whether there is an,
yes,
yeah,
sir.
yeah.
Already we spoke about in the presentation also. Always people want some shortcuts. So they want simple shortcuts, and whatever the people these centers are doing, they are doing some vibration and they are applying. So this is not actually weight loss. That is just dehydration. So whenever they just vibrate, so the fat cannot be lost by just vibration or, with a machine. So people must understand. If once they understand the physiology, then they will stop going. So always the tagline is no side effects, herbal, natural, organic. So these are the அந்த கவர்ச்சிகரமான வார்த்தைகள்னு சொல்லணும் சார். அந்த மாதிரி people are pulling, getting pulled towards it. So probably we have to educate people more and more so that they follow a proper regimen, sir.
Thank you, sir. So another question, where is diabetes, diabetes reversal is possible, and in pediatrics, obesity, any modifications?
Yes, sir. The first
Pediatrics.
question, yeah, the first question regarding diabetic reversal, I would say remission is the correct scientific word. So many, because the reversal has become more of a commercial word nowadays. Diabetes reversal in 90 days program, something like that has become a package thing. So more of a remission will be a right word. So almost in, as per my experience, almost 70-75 percentage of the type 2 diabetics with very strict dietary interventions can be made into achieving proper remission. So remission is HbA1c maintaining below 6.5 without any other drugs. So it is possible, but in another 20-25% people with significant insulin deficiency, definitely support of drugs or even insulin will be required. So diabetic reversal may not, remission or reversal may not be possible for everyone, but at least for 70-75% people with good diet and physical activity, definitely possible, sir. So, but we shall have to understand what is our status, and the people have to follow accordingly, because I am seeing even the wronger people on the wrong side, because insulin deficient people trying for this diabetes reversal, that is dangerous in another end. So they have to do a proper evaluation, do a fasting C-peptide, check whether the insulin secretion is good, then proper assessment and under the guidance of their diabetologist, they have to reduce the medication. They can't just stop the medications altogether. Regarding the pediatric obesity, is the same concept. Actually, we are coming up with the new pediatric obesity guidelines. I'm one of the authors, and it is going to be launched next month. So we are trying to incorporate all these things. So we are trying to move away from the simple eat less, work out more, make children play. So even though we keep saying this repeatedly, we are not seeing, because even in children, the obesity pandemic is rising like anything. So we are trying to incorporate all these and coming up with new guidelines. So maybe once it is out, we will share with the forum so that everyone can get benefited, sir. Thank you.
Thank you, sir. Thank you for the nice explanation.
Thank
And
you,
some more questions for madam. Sir, madam, after getting the first dose, patient discontinued. So the remaining dose, should we restart or we should continue with the same dosage?
It can be, if it is within 1 year, means all the 3 doses can be given within a year. If it is more than 1 year, means the 3 doses has to be started. And another one question I saw, sir, pap smear whether pap smear has to be done before vaccination. See,
Yes.
before vaccination, there is no necessity to, routine screening is to be done. For vaccination, it doesn't mean that you have to do the pap smear and then do the vaccination. So pap smear and vaccination has no correlation. Then after 50 years, as of now, we are extending only up to 45 years. 50 years, if the patient wants to give, means as a what to do, if for satisfaction we can give, but after 45 years it has no effect.
And in which vaccine is good in 26 plus years, unmarried, sexual history not known?
Not history. The 26 plus both are same, sir. Sarvavax is our Indian product. Gardasil is imported product. Both quadrivalent has the same effect. Anything which we can be given. That is not specific.
I think that's the thing. Is any other questions to be asked from the speakers? They can unmute and ask. And in between, if anybody wants to
Sir,
have
good
a
evening,
question.
sir. Sir, good
Yes,
evening. I
madam.
am Dr. Lakshmi Murali, IMA Tiruvallur President, sir.
Yes, madam. Welcome, madam. Welcome.
Sir,
Please, madam.
in Tiruvallur IMA, actually, we have piloted through an endowment scheme from Adayar Cancer Institute, 9 to 14 children. That age group that covered a nearly 100 vaccination, we have given, sir, free of cost to the children. First dose has
Yes.
been given. Thank you,
Yes,
madam,
madam.
for your guidance.
Tiruvallur
Very,
and Viluppuram, Adayar Cancer Institute is giving for Tiruvallur and Viluppuram also.
very good initiative, madam. Thanks
Yes,
for
sir.
sharing the information here so that other branches can also start the initiative.
Thank you, sir.
And, one more question to Arun Kumar sir. So, can you mention the names of the research article you have mentioned in your session so that we can study the articles for our reference and usage, please?
Yes, sir. I've shared a few in the chat box. Yeah.
Okay, sir. Okay.
Okay, sir. Okay, sir. Thank you, sir.
I think, yeah, it's there and they can utilize it. And I request all the members who have joined the meeting
Hello.
to.
Sir, one
Yes,
small
sir.
question, sir. Can I proceed, sir?
Yes,
Dr.
sir. Please,
Srinivas
sir.
from IMA Coimbatore, sir.
Yes, sir. Please, sir.
Sir, regarding the Server Act, girls and boys aged between 9 to 26 has been given as per ma'am's slide, sir. And Gardasil 5 is only for girls between 9 to 45 years. And Gardasil 9 for girls between 9 to 26 and boys between 9 to 14. So what is the real difference between Server Act and Gardasil 5? Gardasil 5, can it also be given for boys from 9 to 26?
Srinivas, sir, this is
Yes,
the
ma'am.
latest update. What I told is that is from the guidelines I told, but the latest update is for the boys, whether Gardasil or Sarvavac, it can be given up to 26 years. It can be a quadrivalent
Okay,
or
ma'am.
equivalent. But that what I mentioned in the slide, it was the old guideline. I should have changed that, but it can
No,
be
ma'am.
given.
The same was actually in Coimbatore, we had a cancer program update 3-4 days earlier, ma'am. The same slide was projected there also. And I wasn't in a position to raise a question at then because I was held up with some other work. So I thought it was a platform to ask to you today from the houses.
If needed, I will send the literature also for you. Both can be given. Boys, it is up to 26 years. That's all.
Okay. Thank you very
Okay.
much. Thank you.
Thank you.
Thank you, Ibrahim, sir, for letting me in.
Thank you, sir.
Thank you.
Thank you, sir. Thank you. So, madam, another question to you in a special scenario where the first dose has been taken and after that the patient becomes pregnant. So, vaccine was not given. And now can we give the subsequent vaccines during the time of lactation?
Yes, sir. Once a bit when they are taking the vaccine, if they are becoming accidentally pregnant, means there is nothing to worry. But the doses has to be stopped, and after delivery, that is during the postnatal period. Now we are once the patient is getting discharged, as we are telling about the contraception, we are giving the vaccine also. It has no side effect with the lactation. During lactation, vaccination can be given.
Okay, madam. Wonderful explanation. Is Dr. Ashokan sir here? Sir,
Yeah,
sir is there? Sir? Yes, sir. Yes, sir. Thank you. So I think no questions are there in the chat box, but being a oncologist, I have some questions here.
Go
I'm
ahead,
basically a surgical oncologist dealing with a lot of head and neck cancers. So what I literally now see is more of the elderly population are still smoking, but younger population, the smoking has come down. What do you think about this, sir?
Probably elderly population, they started at the earlier age, and that is one reason. Second, I think probably the awareness that is being created now, the media, I think the youngsters are probably more towards alcohol. I mean, the previous generation was smoking more, but less on alcohol. The present generation, they drink more. They drink like fish, but the older generation, they were smoking like chimney. And that is the reason. That could be one reason. It started at an earlier age. For example, in the medical college, I think where we studied our alma mater, I think more than 70 to 80% were smokers. Now they stopped it, but still, I think the elders, they continue to smoke. Maybe, they're in the second fag end of their innings, and that could be one reason. And very philosophically, they face the terminal exit. That could be one reason for not really harboring any kind of fear about death or any complications. I think fear is the key for the youngsters. That fear is lessened with the old people. Maybe that would maybe the reason.
Thank you, sir. Thank you for the explanation. Since you mentioned about the fear factor in addiction, I have seen a patient who got, he's a chronic smoker who got carcinoma larynx, radiation given, recurrence. Then we did a total laryngectomy, and patient had a end tracheostomy, and the patient continued to smoke through the tracheostomy.
Oh, he's probably pipe smoking every day.
Yes. And also, I have seen patients who gastrectomy done and drinking alcohol through the Riles tube also.
And
So
especially
addiction
the physical dependence is the worst factor. With its, I mean, tobacco and heroin, they are killers. I mean, cannabis, it is not having any kind of a physical dependence or even psychological dependence. It can be initiated and it can be stopped at any point of time. And probably, they're trying to make medicine out of it. But nicotine and heroin, very difficult to really quit. Maybe in the long run, fear is the key. That's a final word as far as the tobacco is concerned.
Got it, sir. In your own practice, in a lot of your de-addiction patients, what will be the percentage of tobacco de-addiction, sir, which you are facing?
Tobacco de-addiction, I think probably, little bit difficult in the sense, on their own, they stop. Probably if they get CAD, if they get some problems, physical problems, again, out of fear, they stop. But even after CABG, I know some people they start smoking after 6 months period. If the person is able to sustain the quitting even after 1 year, then there is a possibility of calling him as a new leaf. But very frequently they abstain. Very frequently they go for relapse. This is the story of tobacco. So 1 year period is the gold standard for assessing a real motivation and a real quitting.
Got it, sir. We have seen a lot of patients relapsing again and again after multiple times of tobacco cessation.
Exactly.
Yeah. So one more question to madam. I think after first dose pregnancy occurs, second dose can be given. So I think you have already answered, madam. After the delivery, we have to give. How many months after the delivery we have to give the dose, madam?
After 6 weeks, sir, we can start.
After 6. So another question to Asokan sir, is the use of vaping products safer than traditional smoking methods?
Not at all safe. I think from frying pan to fire or fire to frying pan, the heat is still on. I have a question here. I think smartphone addiction and internet addiction. And can I answer this question?
Yes, sir. Please, sir.
When television was launched, I think people were really, criticizing that it will be really, making us to get glued to this particular tinsel frame. But over the years, I think we can't really, it has become part of our life. People talk about smartphone addiction and internet addiction. There is a trial in compiling DSM-5, or I think they wanted to give a nosological status for smartphone addiction. Field trial, I think probably in trial of DSM-5, or it was there. But now they failed to really, include in the nosological status, because in the corona period, you take classes. I think everything was in the net. Internet has become part of our life. Artificial intelligence is probably going to replace our life or replace us also. I think yesterday there was a beautiful article by, M.K. Narayanan in Hindu. It's going to be the main defense as well as offense in the war strategies. Smartphone addiction, we have not really, defined what is smartphone addiction in the true sense. Internet addiction, if you are genuinely using internet or smartphone for 6 hours for your studies or for your purpose, I think it is not addiction. Maybe for other purpose, if you are using it and that is interfering your functional ability, and if you are not really watching television, net, or browsing the net or going for any kind of website, and if you develop behavioral problems, then it is construed as an addiction. But again, I think it's a thin layer that is separating addiction and judicious use. If my profession requires, web browsing, definitely I need to really be there. So everything is done on online. So you have to be there. So this is another one. We call it as a behavioral addiction, but still, other purposes, if you are using it, and if it is interfering your functions, you have, imagine a student is not going to class, imagine a doctor is not attending his clinic, or a teacher is not going to college, then it should be considered as addiction. Otherwise, he's able to do it. I'm not talking about multitasking. If you are using it judiciously, I think it's not addiction.
Thank you, sir, for the nice explanation. And one more question to Arun Kumar, sir. In diabetic diets, what is the role of milk? How often we can, or how can we take milk? Milk can be induced for diabetic diet. Arun, sir? I think sir is not
Sir,
there.
I think
guess.
sir is not.
Yes, sir. I think we have come to the fag end of the session. It was all the three are wonderful sessions, and our chairman sir and secretary sir are here. So I request our chairman, Dr. Nirmal Frederick sir, to give the closing remarks. Sir.
Yeah, thank you, Ibrahim. So it was indeed a wonderful session. My sincere thanks and congratulations to all the speakers, Dr. Sampath Kumari, Dr. Ashokan, and Dr. Arun Kumar, for staying with us and enlightening our delegates. Also, we had a fruitful discussion on many of the areas that has not been covered in the presentations, and also persistent queries from the audience. So thank you all the speakers. It's been a privilege to have you with us this evening. And I'm sure Secretary has something to update. The delegates, thank you for joining us and staying till the end of this program. We're now close to the program, and stay with us in the WhatsApp groups of AMS. Next month, we'll meet with a new topic and important guidelines related to medical specialties. I also wish to invite you all for our AMS North Zone Conference to be held at Tamram, hosted by IMA Tamram in the third week of April. We'll be sending the invitations soon. So thank you for joining us.
Excuse me,
And
sir.
over to you, Dr.
Excuse
Senthil,
me,
for
sir.
your secretary.
Sir, can you hear me, sir?
Yes, sir.
Yes,
Excuse
sir.
me, sir. Hello.
Yes, sir. You are audible. Please go on.
Sir, what is the role of Nicotrex in the smoking cessation, sir? Nicotrex.
Sir.
Bubble gum.
Again,
Ashokan, sir.
Yeah, again, it delivers, nicotine in a lesser concentration, and more than that, I think it is elevating the rewarding effect, and probably it is ideal during the withdrawal state, and it is not really, delivering the content of nicotine as that of a conventional cigarette. So there is a possibility of averting the behaviorally reinforcing effect. But that is not the permanent solution. Maybe ideal for sustaining on Nicorex for 6 months, and subsequently he has to be subjected to other intervention strategies like medications like bupropion and vernaculine, and periodic intensive face-to-face counseling should be there for achieving quit rate for a longer run.
Thank you, sir.
So before we just conclude with a vote of thanks by our joint secretary who has done a wonderful job in coordinating this session, I just want to inform that all the slides with the presentation, everything will be shared in the YouTube link shortly, and it will be available in the IMA TNSB YouTube site. So we request all our members to continuously join these sessions and support us, and at the same time get more knowledge. And I think this session has three different topics not related to each other. So, but still it was very interesting. And thanks to our chairman for arranging the speakers as well. And now I request our joint secretary, Dr. Ibrahim sir, to give proposed vote of thanks.
Thank you, sir. I think we have some of the question on somebody have asked for a link for
Yes,
AMS. So that can also
இங்க
be
தானே
posted.
விளையாடணும் இதுல இப்ப ஊஞ்சல்ல விளையாடுற
pardon, sir?
Sir, if you can share the slides, sir, to the headquarters, we can keep it in our website, sir.
Sure, sir. Yes, sir.
And regarding the diet, and we had annals also. In that also, we had covered extensively about the diet and obesity. Also, cancer also we have covered, sir. That 300 ml of milk is the upper limit for non-carcinogenic effects. Below 300, there is no carcinogenic effect seen, sir. Regarding diet, I mean, like milk and obesity, there were questions. No, but the studies have shown that up to 300 ml of milk, it had not shown any carcinogenic effect. Most probably that also applies for obesity, I think so, sir. Okay, thank you, sir.
Thank you,
Thank
sir.
you,
Thank
sir.
you.
Yes.
Thank you, sir. So thank you, Sendil sir, and thank you all for the opportunity for hosting this IMA AMS second CME of this year, and February's Cancer CME on view of World Cancer Awareness Day. On behalf of our IMA TNSB AMS office bearers, I thank our IMA state office bearers and IMA headquarters office bearers who have kind enough to participate and join. I particularly thank Sairam sir, who has been till the end of the session and participating actively in the academic sessions also. I thank all the three speakers, and all the three topics were very important and very much clinically relevant, and there are good discussions in all the three topics. I thank all the delegates who have participated. The delegates numbers is almost near 500 from the start of the thing till the end. Even at present it is almost 400 plus. I thank all the delegates, and once again I thank my office bearers, IMA TNSB office bearers, for wonderfully coordinating the thing, and also the persons behind this Zoom who are working from the IMA TNSB office there for helping us in coordinating this Zoom meeting. And as our secretary told, we'll have wonderful topics in the near future for the next month and on the forthcoming CMEs also. I request all the members to keep themselves updated in the AMS WhatsApp group, and we will update periodically about the necessary topics and necessary CMEs. Thank you all once again. Thank you.
Thank you, sir.
Thank you, sir.
Thank you, madam. Thank you.
Thank you, sir.
Thank you, everyone.